All right, so we're doing something different today. I'm gonna go through a TMS quiz that we have created for TMS therapists, technicians, treaters, no matter what you want to call this position as. And this quiz is available on our website, so you basically can take this quiz yourself, to kind of test your knowledge generally. But we're gonna go over those questions one by one and answer them together. I might add those explanations of those questions to the video or to the description of explanation of those answers to the online one. So if you want to take it, on our website and then you want to reference back, to all of those, you can do the same thing. So you just enter your email, you take the test, we send you the results, and you have access to all of those videos. All right, let's start with the first question. So Mark and Janet are both depressed and doing and going through TMS therapy. Mark has comorbid anxiety for which he is on Klonopin 1 milligram 4 times a day. Janet has comorbid ADD for which she is on Concerta 54 milligrams every day. They both asked if their medication could affect the outcome of TMS therapy for depression. Which of the following statements are the most accurate? So technically this question is asking you about the effect of medications on TMS, and we have a full video on that, refer back to it on our channel. So option number 1, their medications won't affect the outcome of TMS. Option number 2, Concerta could enhance the effect of TMS for depression, while Klonopin, more than 2 milligrams in a day, could decrease the effect of TMS for depression. Number 3, Concerta could decrease the effect of TMS for depression, while Klonopin, more than 2 milligrams a day, could enhance the effect of TMS for depression. Number 4, both Concerta and Klonopin, more than 2 milligrams a day, could decrease the effect of TMS for depression. All right, so you probably know the answer if you have watched the video about the effect of medications on TMS therapy. So the answer is that stimulants, medications like Adderall, Concerta, what have you, whatever we give for ADD, enhances the effect of TMS therapy for depression. While on the other hand, Klonopin, more than 2 milligrams in a day, could decrease the effect of TMS therapy for depression, particularly more than 2 milligrams a day. And that's based on a paper that I shared in that video. So go back to that video, watch it, you would understand, how the effect of TMS could decrease if somebody is on a high dose of benzodiazepine. Does not mean that there would not be an effect of TMS for depression on patients who are taking benzodiazepines. It's just that we have to explain that maybe we would not have as good of an outcome if we were on a benzodiazepine. All right, okay. Let's look at the next question. All right, the next question says, which of the following can increase the risk of seizure when done concurrently, meaning at the same time with TMS? Number 1, taking Wellbutrin 450 milligrams a day. Number 2, smoking marijuana every night. Number 3, sleeping more than 8 hours every night. Number 4, using CBT app on a smartphone during a TMS session. All right, so you probably also know the answer from this question from the video that we made on the effect of medications on TMS, and the answer is taking Wellbutrin 450 milligrams a day. So Wellbutrin more than 300 milligrams, particularly 450 and higher, has higher chances of inducing a seizure. So if we're doing that, if we're doing Wellbutrin at a high dose, I'm talking about 450 milligrams, and we're doing TMS at the same time, so we could have higher risk of seizure generally for a patient, okay? Let's look at the other option. How about marijuana? Does marijuana affect TMS in any way or shape? Well, we don't have conclusive evidence. We don't have clinical data showing us the effect of marijuana smokers. How do they do with TMS, whether better or worse or what have you. But what we know is that some products of marijuana have been used as anti-seizure medications, right? So cannabis agonist could be used as anti-seizure medicines. What does that mean? It means that they could increase seizure threshold. Okay, what does that mean? It means that a patient who is smoking marijuana could have higher motor threshold than a patient who is not smoking marijuana. So if I'm doing motor threshold determination for a patient, I might need higher intensity if this person is using a lot of marijuana. Okay, so why is this important clinically? Well, if you have a patient who's using marijuana for other medical reasons, say for insomnia and what have you, and they went through TMS, and after say, third week, fourth week of their treatments, they're feeling significantly better in their mood, and they decided, why am I smoking marijuana? I don't want to do medical marijuana anymore, and they stopped smoking marijuana. Well, now we might need to do remapping to kind of measure what is the motor threshold for this patient, because it actually could decrease. Because when we measured the first time, it was while the patient is using heavy, high amount of marijuana. When that patient stopped or decreased their marijuana significantly, their motor threshold could change, okay, meaning that it could be lower, okay? So if we do not lower the intensity of treatment, we could increase the risk of seizures then, okay? All right. So, but that's not the correct answer for this question because it's the opposite in here. Okay. How about number 3? Sleeping more than 8 hours every night. Yeah, sleep deprivation could decreased motor threshold. This is oversleeping, not sleeping too much. Using CBT app on a smartphone during the session. If somebody is, cognitive behavioral therapy is useful during TMS. That's why I put this one in here. So we want to understand that it actually is better if somebody is going through cognitive behavioral therapy. And currently there are multiple apps that you can use on your phone, for enhancing positive thoughts and what have you and stuff of this sort. And it doesn't have any effect on seizures or no seizures. Okay, all right, okay. So let's go to the third question. This question, all of the following describes TMS therapy except for one. Number one, TMS therapy is an alternative treatment for depression. Okay. TMS therapy can work when psychotherapy and medications don't. Okay. TMS therapy is an invasive procedure. Okay. TMS uses magnetic pulses to activate areas of the brain that are hypoactive in depressed patients. Okay. All right. So you can see that the third one, TMS therapy, is invasive procedure. It's not really invasive. Okay. Because we're not invasion. Invasive procedures is when we have to kind of cause a cut in a patient's body or administer something invasively, right? Let's say, open heart surgery is an invasive procedure. Placing a deep brain stimulator in the brain for Parkinson's disease, for seizure disorder, for depression, those are invasive procedure, okay? How about ECT or shock therapy? Well, the jury is out on that because we're delivering electricity to the brain. So in some opinions, this is considered as being invasive, okay? Now with TMS, we don't need sedation. There is nothing that is causing extreme pain to the patient or what have you. Patient is completely alert and awake during the treatment and what have you. So technically, it's non-invasive treatment. Okay, and I my language here might not have been the best when I said TMS therapy is invasive procedure. I put procedure as well because TMS is not a procedure. Okay, so that was a debate that was taken when TMS got FDA approval. Like, what are we going to call this? Is it a procedure? Is it therapy? Is it treatment? And there was a debate about that. So the best way to solve this debate was to call it therapy, so TMS therapy, because then a therapist, technician who's doing TMS can actually administer the treatment under the supervision of a psychiatrist, while a treatment means, medications, and then you need certified nurses to kind of give medications and what have you, for a treatment. Procedure means that it's invasive, which is not really the case, all right? So, the naming of TMS, was out of this, description in here, okay? So the answer to this question, all of the following are correct except for the third one. All right, let's go to the next one. This next question, Lily is a 29-year-old new mother. She delivered a healthy boy 2 months ago. She's breastfeeding and plans on continuing doing so for about a year. She is severely depressed. She tried CBT and it did not work for her. She asked, what is the safest depression treatment for me that won't affect my newborn? Okay, and the answers here are CBD, medical marijuana, TMS, ketamine. All right. Obviously, I am biased and I do TMS, as the main thing. I also do esketamine. So obviously, the answer here is TMS. Okay. But all of the other options, we're not 100% sure that they're safe for her newborn, except for TMS. Okay. Because basically, she's worried about any chemical that would be produced or exerted in her milk for her newborn that she's breastfeeding. Okay. So TMS, she's coming here to the clinic, doing her TMS treatment, going home, and then breastfeeding her baby. There is no exertion of chemicals from a treatment that she's taken that would affect the newborn. Okay. All right. Next question. All of the following are TMS clinics in Tampa Bay area except for one. Okay, you don't need to worry about this question. This is more local question for the Tampa Bay area. I want my staff to know exactly the names of machines, clinics, etc. So you have to adjust this question to your local area to make sure that your staff do understand, all of the clinics in the area. But we can answer this one. So all of the ones are TMS clinics except for one. So Greenbrook is a TMS clinic. It's actually around the country. I think they have about 150 treatment clinics around the country so far. NeuroSpa is a colleague of ours. They have about 6 clinics in the Tampa Bay area. NeuroStar is not a clinic. NeuroStar is a manufacturer of a device. Okay, so that is the answer in there. And Florida TMS Clinic, that's our clinic. All right, let's go to the next question. TMS therapy is FDA-cleared, which means indicated. Indication of a medication is when can I prescribe a medicine to somebody, right? So if I say, let's say, for example, Seroquel is indicated for schizophrenia, okay? That means that it's FDA approved for the reason of schizophrenia. It does not mean that everybody with schizophrenia have to give them Seroquel, okay? But it's an option, to be given this medication, okay? So that's what this means. So TMS therapy is FDA-cleared, indicated for treatment of major depressive disorder in adult patients who have failed to achieve satisfactory improvement from prior antidepressant medications in the current episode. Based on the above statement, for TMS to be used as indicated, meaning on label, the patient should have tried at least 1 antidepressant, 2 antidepressants, 4 antidepressants, or 4 antidepressants, 2 augmentation treatments, and psychotherapy. All right, I'm going to give you a second to think about that. Based on the FDA clearance for TMS, how many medications should the patient have tried for this to be on label, to be as indicated? The answer is 1 antidepressant. Okay, so this is the FDA clearance. So the FDA clearance was based on the research that showed the efficacy of TMS, and the major pivotal trials. The inclusion criteria was failure of 1 antidepressant. So why did they not do it on patients who had never tried antidepressants before? Because if you haven't tried antidepressants before, the placebo effect of the first treatment for depression is pretty strong. So whether you do cognitive behavioral therapy, you do yoga, you do aromatherapy, you do light therapy, it doesn't matter what it is, you have higher chances of responding from placebo effect. But once you have failed the first antidepressant, and we're looking at the second antidepressant medication, now the placebo effect is significantly less. So every time they wanted to create a pivotal trial to prove the efficacy of transcranial magnetic stimulation, they particularly excluded patients who never been on antidepressants before. Okay, so that's the reason why the FDA clearance is 1 antidepressant before. Okay, let's hold for a second. What does that mean? If somebody had never been on an antidepressant and they are of the opinion, I don't want to take any chemicals, I want to treat my depression without antidepressants, can they do TMS? Of course they can, and they could have, they're supposed, or at least we would assume that they will have higher benefits because they haven't failed anything before. But we have to explain to the patient that this is off-label treatment now, right? Because the on-label treatment is failure of 1 antidepressant, right? So yes, they have high chance of responding to TMS, but we have to explain it as off-label treatment, okay? Now, all of this is different than insurance criteria. Insurance criteria is mostly the fourth one, which is failure of 4 antidepressants, 2 augmentation, and psychotherapy, okay? It is not based on science. It's based on saving money. It's based on cost effectiveness of treatments. We will talk about that when we talk about the cost of TMS, okay? So we have to understand the difference between the FDA clearance indication for TMS therapy and what insurances are approving or not approving. Okay, all right, let's go to the next question. Donald is a 67-year-old male who is suffering from depression for 2 years. He tried more than 4 antidepressants from 2 different classes of antidepressants, 2 augmentations, and CBT without improvement. He went through TMS therapy and he did well. His MADRS, this is one of the rating scales that we use for depression, decreased from 42 to 12 after TMS. He continued to see his psychotherapist. 6 months later, he is depressed again, and his MADRS now is 24. He asked if his Medicare plan will cover his second course of TMS therapy. Okay? All right, let me summarize the question. This is somebody who went through TMS. They did well. Their MADRS decreased from 42, which is severe depression, all the way to 12, which is basically remission. Okay? And then after 6 months, he continued to do psychotherapy. After 6 months, he's in another depressive episode. And now his MADRS score is 24, okay? And the question asks, can he do TMS therapy again? Is his insurance going to cover it or not, all right? So the choices are, number 1, yes, because he showed good improvement with the first course of TMS therapy, and it had been over 2 months since the first TMS therapy course ended. Number 2, no, because it has not been a year since his last TMS therapy course ended. Number 3, no, because his current episode of depression is moderate, not severe. Number 4, no, because his TMS therapy can be done only once in a lifetime. Okay, so the correct answer to this question is no, because his current episode of depression is moderate, not severe. Okay, a lot to dive in here, okay? So, though this patient had responded to TMS therapy in the past, and his rating scale went down from severe depression all the way to remission, and then though his improvement lasted for good enough time, meaning that it was durable response, okay? Durable response meaning at least more than 2 months, okay? Some insurances require 3 months, some insurances require 6 months. But by the science, we consider, depression that comes after 2 months from the first episode to be a recurrent depressive episode rather than a relapse. So though it was over 2 months, since his response, so it lasted really well, when he got depressed again, now his depression is not severe. Okay, so per Medicare, the depressive episode has to be severe, which means MADRS score of 36 or higher, okay? And his MADRS score is 24, okay? So we need to understand rating scales, and we need to understand what is each of those rating scales indicate, as a severity of the depressive episode. So as of now, he does not qualify per his insurance for another TMS course, okay? At some point, if he continues to be depressed and it gets worse over time to a level of severe depression, then yes, he would qualify for a repeat course of TMS. I apologize, I don't make the rules. This is what insurances, indicate. Again, it's based on cost saving. It's not really based on science. If you ask me science-wise, yes, I would want him to be treated again at moderate depression, because we want to prevent a full severe depressive episode from happening. And in my clinic, we do what we call rescue TMS, meaning shorter course of TMS, completely for free to the patient in this situation to prevent the patient from going back into severe depressive episode. But these are the rules for insurances, and I want you as a TMS treater to know the rules. Okay. All right, let's look at the other options, because some of them are interesting. The option number one, it says yes, because he showed good improvement in the first course and it was over 2 months. I throw the 2 months in there because I wanted you to know that the science says 2 months. Some insurances say 3 months, some insurances say 6 months. The second option, no, because it had not been a year since his last improvement. That was an old criteria from a couple of stingy insurance plans who did not want to do multiple courses of treatment. They said once a year, right? So that's not the rule anymore, because it's totally stupid to kind of like prevent somebody from having another course for only once a year. There are people who get recurrent depressive episodes significantly more frequent than once a year. And the fourth option, no, because TMS therapy can be done only once in a lifetime. Absolutely not true. You can do it multiple times throughout the lifetime. It's similar to how somebody will have multiple depressive episodes in a lifetime. Okay, let's go to the next question. Which of the following insurance does not require prior authorization prior to starting TMS? The patient must still meet the criteria, but no need to obtain prior authorization. Which insurance is this? Number 1, United Healthcare, which is Optum. Number 2, Florida Blue. Number 3, Medicare. Number 4, TRICARE. Now, I'm talking about Florida as my state, but this applies to almost every state, okay? The answer to this question is Medicare, okay? So Medicare does require have very strict criteria for who qualifies for TMS, but they do not require prior authorization, meaning that you as a technician or office manager for TMS practice, you do not have to fill out a form and send it to the insurance company to get a prior authorization for the treatment before you start the treatment, as long as the patient meets the criteria. If they don't meet the criteria, you're not going to do TMS and bill Medicare for that, okay? All right, now why is this the case? Because, it's a government entity and you're always at the risk of an audit in case that they find out that you're crossing some of the rules. The clinic will be audited by Medicare, and then it's federal like crime or felony or whatever it is, then it's a big deal, because you're actually committing fraud against a federal entity, right? So there is a second layer of protection. That second layer of protection is in case of an audit, if in case that you're not doing the right thing, okay? But the bottom line here is for TMS technicians or office managers, what you're trying to do is you need to have really good documentation. You need for sure making sure that you meet the criteria in your state for Medicare, and you can proceed with the treatment. You submit the bills, and you should be fine, and your patient should be covered under that rule. All right, next question. TMS therapy can cause the following side effects except for one. So everything is correct except for one, okay? So seizure, yes, it's one of the side effects that could happen with TMS. Extremely rare to happen. We're talking about, initially we were thinking 1 in 30,000 treatments. Now the data is showing us it's about 1 in 89,000 treatments. Okay, I repeat, 1 in 89,000 treatments. Not that many clinics, that do, more than 30,000 treatments in a year, right? My clinic, I have been doing TMS since 2019. We, I think, are now around 30,000 treatments that we have done. We've never had any seizure happening, but I'm telling you of how rare it is for a seizure to happen, but it's still reported. Number 2, headache. Yes, this is a side effect that could happen with TMS. Usually it's discomfort of the scalp where the tapping sensation is happening, but sometimes patients could have headache during the treatment, about 30 minutes after the treatment. As they go on with multiple treatment sessions, they get used to it and the headache would not happen any farther. Some patients could have a little bit longer headache than that. I can recall maybe 2 patients that we stopped the treatment because of headaches. One had, a chronic neck pain that, was causing significantly severe headaches anyways, and another patient that was severe fibromyalgia and just got irritating and it exacerbated her pain. And those are the only 2 patients that I recall that I had to stop TMS because of the pain. All right. Number 3, memory loss. Absolutely not. Okay. All right. Now, would somebody go through TMS and then they report to their doctor that they have memory loss? Of course, yeah, then there is nothing wrong with that. But if we're talking about randomized control trials, when patients would not know whether they're receiving active TMS treatment or placebo or sham, what we call it for machines, receiving sham, meaning that the machine is making noise similar to TMS, given tapping sensation similar to what patients will feel during the TMS treatment, but not really delivering any active magnetic stimulation. If we compare cognitive testing of those patients who receive sham with cognitive testing of those who receive TMS, there are no differences between the two, okay? There's no cognitive decline in the active group compared to the sham group, okay? That being said, most of the pivotal trials that did, randomized control trials to do this, they actually noticed the opposite, improvement cognitive function of patients who received active TMS compared to patients who received placebo. The most recent one that detected that was Sandpaper, okay, the Stanford intelligent neuromodulation therapy, right? The one that's accelerated TMS basically. In that paper, they actually detected that there is improvement in cognition in patients who received, TMS. Now, that being said, we don't know whether this improvement in cognition is because we're activating the frontal lobe where we actually, do our cognitive function, or whether it's just because depression was less or it was relieved in those patients who are receiving active treatment. To be quite honest with you, I don't care. All I care about is that I want to tell my patient that there is no cognitive impairment that happens with TMS. If anything, it's the opposite, okay? All right, why is this important? Because when we're comparing TMS to ECT, ECT could cause cognitive impairment. TMS does not cause cognitive impairment, okay? I am aware of some patients, kind of complaining about feeling foggy or whatever, during TMS. There is a placebo effect that could play a role in that. If somebody is too anxious about TMS, or they read something online, there are Facebook groups particularly talking about all of this, and I can even think of a person who was trying to kind of contact any lawyer who would take this as like a class action lawsuits against TMS manufacturers, that it causes cognitive impairments, and no lawyer took it because they reviewed the literature. They would see if that was actually detected or not detected, with objective testing. So that's not the case. All right, so rest assured that this is not an issue. All right, number 4, tinnitus. Okay, tinnitus is ringing in the ear. Okay, I think Americans would say tinnitus, British would say tinnitus. Okay, so whichever way you want to pronounce it. All right. Okay, so ringing in the ears could happen with TMS. All right, so this is one of the reported side effects. Now, it seems like the main reason for tinnitus to happen is because of the imbalanced noise. You were putting the coil on the left side of the head. It's making a noise similar to an MRI machine. So, and then it stops, and it goes again, and then it stops. So when you're exposing yourself to loud noise like that, the decibels of that is between 70 to 80 something, right? At least, measuring here in my machines. It depends on the intensity, but it's a loud noise, right? So that could cause imbalanced, vibration in your ears, and that could cause, tinnitus. If we use foam earplugs and put it in our ears during the treatment to protect that vibration from going to the ears, then it seems like for clinical research there was no detection of any problem with tinnitus or hearing loss. Okay, so it happens only if you're not using protection. Okay, so use protection, kids. Sorry. Okay, so use hearing protection with foam earplugs, similar ones that you use around loud machines and what have you and stuff of the sort. All right. Now, there's another theory for why this happens, which could be, just the effect of TMS on the neuroconnectivity of your brain that could induce, tinnitus and what have you. But to be quite honest with you, based on the clinical data that we have, that when patients are using hearing protection, they do not report any tinnitus or hearing damage or what have you. Then for this reason, I don't think it's actually a change in the neuroconnectivity that causes tinnitus. I think it's most likely, the damage from the outside. All right. That being said, TMS could be used for tinnitus, okay? So there is a VA trial that had, I think, 40 patients that they looked at them, and they had tinnitus because of exposure to loud noise explosions and what have you. And they found that patients who received TMS, they had reported less severity of their tinnitus. I can, at some point, if you're interested and you have a question about it, I can share it on a video for that particular results, okay? All right, by the way, also, there is a single pulse TMS device that is used for migraine headaches. So remember when we were saying that TMS could cause headaches? There is a particular device that is single pulse that you do during the aura time, with migraine headache, that will prevent or would abrupt the migraine episode from happening. Okay, so the answer to this question is that yes, TMS could cause seizures, headaches, tinnitus, but it does not cause memory loss. All right, let's go to the next question. Which of the following insurances has the least restrictive criteria for TMS? Cigna, Aetna, United, TRICARE. Okay, so this is a review for you as a TMS technician, office manager, or what have you, to kind of understand the policies in your area. Now, I am in Florida, and this is, the answer here in this question is for Florida, but you have to look at your own policies in your own state with each contracted insurance that you have. Cigna requires failure of 2 antidepressant medications. They don't mention anything about augmentation, so they don't require augmentation. Cigna will approve TMS for moderate depression. Remember when we talked about MADRS score and you have to be in severe? Cigna doesn't do not have to be in severe. Moderate depression, depressive episode should be fine. Okay, Aetna requires failure of 2 antidepressants. The duration of trial for each of those antidepressants is 8 weeks, okay? While Cigna, for example, is 4 weeks, okay? So for Aetna, the duration of trial for each medication is 8 weeks, and they require 1 augmentation at least, and obviously psychotherapy. The problem with Aetna is that they do not have criteria for intolerance of medications. So almost every other insurance has a criteria that you can go for TMS if you did not tolerate antidepressant medications, meaning that you had side effects with medications, with antidepressant medicines. Aetna does not have that, though the patient has to try medications. Despite trying medications, despite having side effects, go figure, this is Aetna, okay? United requires 4 failures of antidepressants, 2 augmentation treatments, and psychotherapy, okay? So this is the most restricted criteria out of those. Again, I'm talking about Florida, all right? And they do have intolerance criteria, intolerance of 4 antidepressant medications from 2 classes of medicines. TRICARE, this is the active military and military insurance and what have you, they stick to FDA clearance, okay? So meaning that if the FDA now is saying, failure of 1 antidepressant, then it's 1 antidepressant, okay? So out of those, the least restricted criteria would be TRICARE. Now, again, this is for Florida, you have to kind of check with your own policies for the area that you cover. All right, let's go to the next question. What is the success rate of accelerated TMS in SANT-TRD trial? Ugh, okay, all right, that's a tricky question. I want my staff to know this answer, because they're seeing this on the news. We do provide accelerated TMS, not in a SANT protocol, meaning that we do not have functional connectivity MRI. So we do 10 sessions a day. Each session is 1800 pulses. They're separated by 50 minutes. We do it over 5 days, and we've been doing this before SANT was published. I was aware of SANT of the paper that was ongoing at that time, but we did that since early 2020. We did a modified accelerated TMS in 2019 as well. That's a topic for a completely different video when I will explain to you everything about accelerated TMS. This is in the cooking now, to kind of make sure that everybody understands the pros and cons and knows the secrets behind SANT-TRD. Okay, all right. But anyways, there was a paper that was published in 2021, which was the clinical trial was done from 2018 until 2019, I think, or something of this sort. And basically, 22 patients were recruited in the trial. 21 patients completed the treatment. 19 out of 21 remitted with the treatment with accelerated TMS. So based on that, the reported response rate was 89%, which is basically rounded to 90% in here, okay? So the response rate was 90% with that treatment, okay? All right, so that's what was reported. Now, there are a couple of caveats to this. Number one, it was open label trial, meaning that there's a placebo effect in there, right? Obviously going to Stanford University, seeing the greatest guy with, in the TMS world today, which is our colleague, Dr. Nolan Williams, and doing leaving your work job, whatever it is, for the whole week, just for this whole treatment, getting that excessive care during that time with a couple of MRIs before and after, and so many questionnaires and care and what have you, that has a strong placebo effect. Okay, the good news is that there was a randomized control trial that was published a year after that, which is SNT, right? So they tried to simplify the abbreviation for the clinical trial to SNT, and that one also showed significant separation between active and sham. Okay, the number is not 90% in that second one. The number is difficult to report. I would say that they would tell you it's 79% response rate, but there are more details about that. Because the report of response was not only at the end of the treatment. They counted response even if it happened at any week in the first month after the treatment. Okay. Anyways, that's for that detailed topic. But what I want you to know as a TMS technician is that when patients are asking about accelerated TMS and they're saying, hey, I heard that it's really good and the reported response rate is 90%, is that right? Yes, you have to understand that this is what's reported in the SANT open label trial. Here's one thing I want you to know though. If we look at those exact same patients who did accelerated TMS, did 50 sessions in 5 days, and then we look at that same sample 1 month later in week number 5, the response rate is 60%. Okay, so I repeat, the response rate with accelerated TMS, when we do 10 sessions a day for 5 days, total number of treatments is 50, is actually 90%, okay? If we're looking at those same patients in 5 weeks after the treatment, the response rate is 60%. So that's why I put the number 60 in here, okay? All right, why is this important? Because conventional TMS in open label trials has a success rate of 58%, which is about 60%, right? And basically this is 6 weeks duration, right? From the moment that you start until you end. If you're gonna count 1 week of accelerated TMS and then 5 weeks after to kind of see who is still hanging in there, and then you're gonna reach the number of 60%, Good, that's the same thing. We already have that, right? So for this reason, I don't really answer when patients ask me, if accelerated TMS is better than conventional TMS. Though I do both, I usually am very careful to say that accelerated is better. I will tell them that it's more practical, it's faster, but I can't really say that it's better, okay? Again, more to come about that in a separate video. All right, let's go to the next question. All right, so MagStim TMS therapy, Horizon Performance with Stim Guide, uses magnetic coil that is best described as H1 coil, H7 coil, F8 coil, or DB80 coil. Okay, so there will be a very detailed video about different types of TMS machines. That is going to be a little bit hot topic on my channel, and I bet that a lot of people are going to share this video. Okay, but I also want every TMS technician to know all TMS machines. Unfortunately, one of the things that happens in your field is that the manufacturer of the device that you have is the one that is providing your education. Okay, so what is going to end up happening? You're going to be limited only to what NeuroStar told you, or to what BrainsWay told you. You would not understand, or what MagStim told you, right? You would not understand different coils and different other treatments, and you would not understand, whether, what is superior, what is inferior, etc., etc. Now, I don't expect you to become a TMS psychiatrist tomorrow, but at least I want you to know what you're using, what you're dealing with. Okay. So for my staff, we use MagStim TMS therapy device, and that is F8 coil. Okay. What does F8 means? It means figure of 8 coil. Okay. So that means that there are the wires of the magnetic coil are like two circles connected with each other, similar to the number 8. Okay, so figure of 8, in a figure of 8, if you tilt it around, then this is the infinity sign kind of thing. Okay, so machines like NeuroStar, they use figure of 8 coil. McVenture uses figure of 8 coil. MagStim uses figure of 8 coil. NextStim uses figure of 8 coil. Apollo from Mag and More, they uses figure of 8 coil. Cloud TMS from Neurosoft, they use figure of 8 coil. Okay, all right. Now, H coil, basically the wires of the coil goes in a line, it crosses back, it crosses over, it goes in another line, just like the letter H. Okay, and then it continues to do this, in a certain fashion to create a helmet design kind of thing that you put on the head, and then it stimulates larger area of the brain. So H1 coil is produced by BrainsWay. Okay, so this is the only manufacturer that is producing H-shaped coils. Okay, and I put that in quotes because H7 and H4 are not really that much H. We'll get to that in a second. Okay, but H1 coil is a depression coil from BrainsWay. It's also now FDA cleared for anxious depression. By the way, figure of 8 coil now got FDA clearance for anxious depression. Okay, but anyways, H1 coil provide larger area of stimulation to the brain because of that shape of H for the wires that goes in. So it's more diffuse area of stimulation. Actually, there is some stimulation that goes into the other side as well with H1 coil. So sometimes even when you're tilting it to go for the left DLPFC, you'll have some stimulation in the right frontal lobe as well. The problem with that is that it could cause more side effects. You could have a little bit more seizures that could happen with H coil, and you for sure will have more discomfort of the scalp in the area when the patient is getting treated, meaning more headaches that could happen with H1 coil. Okay, all right. Now, BrainsWay would like to call it deep TMS. Okay, DTMS. That's a different discussion that I might go through, like the protocols of TMS and what have you. But that's not really like a scientific classification of TMS. Like rtms, R stands for repetitive. ITBS stands for intermittent theta burst stimulation. Intermittent theta burst stimulation is under the umbrella of rtms. It's still repetitive transcranial magnetic stimulation. And deep TMS or DTMS is still under rtms, right? There is nothing new there, from the science standpoint. So it's a descriptive brand that they created called DTMS. Actually, they sent cease and desist letters to doctors who could use, deep TMS to describe DB80 coil, for example. I had a colleague who received a letter from them saying that it's a brand name, which re-emphasizes what I'm saying. It's not a science, just branding exercise, okay? And I prefer D to be diffuse, when we're describing DTMS, because that's the main unique thing about H coil, okay, that it stimulates larger area, more diffuse area of the brain, okay. Any coil, any figure of 8 coil, you can make it large enough and increase intensity to go deeper in the cortex, so deeper is not better, you can, and if that's the case, then just make your coil larger, and you will penetrate deeper for figure of 8 coil, okay. H7 coil is produced by BrainsWay as well. This is the one that got FDA clearance for the reason of OCD, or obsessive compulsive disorder. Now, if you look at the characteristics, the machine characteristics of H7 coil, It's actually double cone coil, okay? Meaning that there are two circles of wires similar to a cone in shape, and another one, and they're tilted in about 145 degrees, okay? And then there is some wires in between, you know, for whatever gimmick, you know, to kind of get the pattern that they needed to get. But this H7 coil is basically mimicking DB80 coil. Now, DB80 coil from McVenture got FDA clearance for OCD, but it was used, you know, before the times, you know, that they were always, you know, they had this coil for clinical research, you know, reasons and what have you. So now the H in the naming of that coil lost its meaning because it doesn't look like an H anymore. It looks like a double, you know, cone coil, right? You know, so you can understand when I said it's branding exercises rather than really reflecting the science. So, you know, I don't see the point of why they're calling them H's anymore. And there's another coil by Brainsway called H4 coil, and that's for smoking cessation. And guess what? It looks exactly like the H7 coil. To a point that I actually got substantial equivalent clearance from the FDA for that coil. You know, so they tell doctors it's a different coil, but they tell the FDA it's basically the same thing, right? Okay. Figure of 8 coil, I already told you about that. That's the one that looks like two donuts connected to each other. And DB80 coil, that is produced by McVenture, and this is for OCD, and it's double cone coil. Okay. All right, I took a long time, you know, to explain that, but just know your machine and know what type of coil it is, because when you get a phone call or when you're talking with a patient and they're telling you about like, oh, I heard this about deep TMS, you need to understand that your machine, if it's figure of 8 coil, does not deliver deep TMS, okay? All right. Let's look at this next question. It's a little bit long question. All right. Cassandra, interesting name, okay? I don't know how I came up with that, all right? Is a 24-year-old female who called for her extreme mood swings and sadness. So she called your office. She's saying, I have extreme mood swings and sadness. She had been depressed for 2 years. She was tried with CBT, DBT, IPT, and none of those therapies had helped. CBT is cognitive behavioral therapy, DBT is dialectical behavioral therapy, IPT is interpersonal therapies. All of those are considered to be evidence-based therapies for depression. DBT particularly is helpful for borderline, but it's also beneficial in depression. She had tried over 7 antidepressants, including Prozac, Effexor, Wellbutrin, Remeron. Notice how I mentioned medications that are from different classes of medications to kind of satisfy all the criteria. Her doctor also tried her on mood stabilizers in addition to antidepressants, including Seroquel, Latuda, and Lamictal. So basically, I'm telling you that she had augmentation treatment in the past. She said that for the last 2 months, my highs are too highs and my lows are too lows. Okay, all right, so if you work in the mental health field, you've heard this before, okay? This is what patients will describe when they have either bipolar disorder, meaning that they will go into like a week when they're manic, and then they will go for a few weeks when they're depressed, or borderline personality disorders, when this will happen like over a day or two. Like, you know, a day I am really in a good mood, a day I'm really in a bad mood, or what have you. She explains that her extreme emotion swings do not last more than a couple of hours. Okay, so now we're thinking more borderline. She gave an example when she got into a fight with her girlfriend, which turned physical, okay? So she is impulsive, all right? Her friend pulled her from her hair, which caused Cassandra to fall on her head and pass out, okay? So there's a head trauma now, okay? She since then has intermittent seizures for 1 to 2 minutes at a time, okay? So the head trauma caused seizure disorder now, okay? The story is getting complicated. She saw a neurologist last week, but he was awful. So she described him as being awful. Again, I'm hinting back to the borderline personality disorders. Usually you will have splitting. Splitting means that, you know, you will go to the extremes. Oh, this doctor is awful, this doctor is amazing, etc. She never went back to follow up. On a further review of her records, you notice that in the past she was diagnosed with MDD, bipolar type 2, generalized anxiety disorder, borderline personality disorder, and seizure disorder. Cassandra should not have TMS therapy because of one of the following reasons. Okay, so I give you a complicated case of a patient that could have bipolar disorder, could have borderline personality disorder. She has head trauma recently, and then she has seizure disorder, okay? And then I told you, you are not going to do TMS therapy for this patient. Tell me why. What is the reason that is an absolute contraindication, or it's a strong contraindication for TMS in this patient? Number 1, because patient has bipolar disorder. Number 2, because patient has borderline personality disorder. Number 3, because patient has seizure disorder. Number 4, patient had not tried enough medications for depression. So I'm gonna give you a second to think about it. All right, second is over. All right. So the reason is because she has seizure disorder. That's why you're not going to be doing TMS therapy for this patient. Okay. All right. You are like, but are you going to do TMS for somebody with bipolar disorder? I could. All right. So, from the indication standpoint, no, it's not FDA cleared for the reason of bipolar disorder. But let's say we have a bipolar patient who last manic episode was about 6 months, a year ago, and since then they have been in a severe depressive episode, and they have tried medications. The depressive episode is severe enough that we tried antidepressants. I know that there is a little bit of controversy whether you should give an SSRI to somebody with bipolar disorder or not. I'm saying this person is on a mood stabilizer, had not had manic episode in about a year, had been depressed all of this time. You gotta do something about their depression, right? And you have tried SSRIs and nothing is working. Would you try TMS? Yeah, it's the same risk that you have with SSRI-induced mania that you could have TMS-induced mania, right? That doesn't mean that you cannot do it. You can do it as long as you're watching out for it. And if a patient turns manic during TMS therapy, you just stop the treatment and you watch them for the next few days. You can re-challenge them with TMS again, or if it was severe enough of symptoms, you don't need to put them back on the TMS machine, because they're not depressed anymore when they're, trending towards hypomanic or manic or what have you, okay? So it's not an absolute contraindication, all right? Now, I don't think this patient has bipolar. I was kind of drawing the picture for you to kind of suspect borderline, right? So what if somebody has borderline personality disorder? Can you do TMS? Yeah. Borderline personality disorder is a personality disorder it's access to. A patient could have comorbid depression with their personality disorder. So you could have MDD, major depressive disorder, that's severe, and you could have borderline personality disorder. Now, if you were treatment and having borderline personality disorder increases the chances of treatment resistance, meaning that you would not respond to classical psychotherapies and medications. So can you use TMS then to treat the depression? Yes. And I think there was a paper that shows independent response of TMS, despite borderline personality disorder. Usually it's the opposite. If somebody has borderline personality disorder, it's an indication for failure of whatever antidepressant treatments that you're using, not for TMS. You can still use TMS to treat depression in somebody with borderline personality disorder. That being said, you still have to address the borderline personality disorder from the standpoint of doing dialectical behavioral therapy. You still need therapy for that reason. Okay. Now, but if somebody has, that's the third option, if somebody has seizure disorder, no, I do not want to do TMS therapy for that patient. And particularly this patient, I told you that she had recent seizures, and she saw the neurologist, and she did not like him, and she did not go back, meaning that she is not stable on her medications for seizures, right? She's not compliant, she's not taking anti-seizure medications, and seizures are still happening. And the seizures are happening probably because of the head trauma that she had recently. So that's another reason why we should not be doing TMS at this point for this patient. Let's say for about a year, she's doing okay with her anti-seizure medications. The neurologist evaluated her like, hey, you have been seizure-free for the last year. I'm gonna taper you off of your anti-seizure medications. And then she comes to you and she said, I had a history of seizure before. Can I do TMS? The answer is yes, you can do TMS because you had this history. It's not active seizure disorder, and you have been off of medications for about a year or so. Okay, the fourth one is that she had not tried enough medications for depression. Come on, this lady had been on so many medications before. That's not the correct answer. All right, hopefully this question was good. All right, let's look at the next question. Sandy is inquiring about TMS therapy. She got depressed in 2019 after her husband died in a car accident. She had tried Paxil 20 milligrams for 6 months, which did not work for her. Her doctor added Wellbutrin to her Paxil, and she took both for 2 more months. So for 2 months, she overlapped between both Paxil and Wellbutrin. That's augmentation, all right? Her doctor, this still did not work. Her doctor stopped Paxil and kept her on Wellbutrin as a monotherapy for depression for 6 months, okay? Though initially it helped her some, but not anymore. Her doctor referred her for cognitive behavioral therapy, which she did. After 3 months, she was still depressed. Sandy has Aetna as her primary insurance. She asks, is insurance going to cover the cost of TMS therapy for me? All right, okay. And then, you see the options in here. Yes, because you have failed 2 antidepressant medications from 2 different classes and one augmentation and 1 psychotherapy. Number 2, no, because Sandy did not fail 2 antidepressants from 2 different classes and 2 augmentation and psychotherapy. Number 3, no, because Sandy did not fail 4 antidepressants from 2 different classes and 2 augmentation of psychotherapy. And number 4, no, because Sandy medications trial did not include medicines from the class of SNRIs. Okay. All right, so the gist of this question is that we need to know each criteria for each insurance, for TMS. And for Aetna, it's failure of 2 antidepressants and 1 augmentation. The key here is that this patient was tried on 2 medicines only, right? Paxil and Wellbutrin, right? So those are from 2 different classes of medications. Where's the augmentation? The augmentation was when we overlapped between the 2 medications. So when her doctor started her on Paxil and he was doing that for monotherapy for 6 months, that was one medication trial. And then he added Wellbutrin and he sat down on those 2 medications together for 2 months for augmentation reasons. and she did not do well, right? And he was like, okay, well, let's take the Paxil out and keep the Wellbutrin and maybe optimize that while we're doing cognitive behavioral therapy, right? And then he did Wellbutrin on its own, right? And she did not respond, right? Now, with only 2 medications, we satisfied both criteria. One is 2 antidepressants from 2 different classes, because Paxil is an SSRI, Wellbutrin is norepinephrine dopamine reuptake inhibitor, so it's from a different class. And we satisfied the augmentation criteria, because one of the augmentation criteria is using 2 antidepressants from 2 different classes, okay? All right, and obviously she has psychotherapy. So the answer is the first one, which is yes, she had failed 2 antidepressants, 2 different classes, and augmentation and psychotherapy. All right, notice how tricky this question is, but this is a real life scenario. You know, I do see those cases, right? So you need to be aware that you're not going to turn away or prevent your patient from accessing TMS because of your lack of knowledge of that she actually meets the criteria for her insurance, okay? So, you know, knowledge is power. I sound like whatever his name Lopez. Knowledge, right? Anyways, that was a joke. All right. Next question. Compared to TMS, to rtms, which of the following statement describes ITPS? Okay, now we're getting into a little bit of details, okay? So the first one, ITPS is at least as effective as rtms in treating TRD, which is treatment-resistant depression. Number 2, ITPS is better than rtms in treating TRD. Number 3, ITPS is more expensive than rtms. Number 4, ITPS takes longer time than rtms. Okay, now this should be an easy question, but you know, if you don't have, again, you know, this whole educational series is aimed for TMS technicians and treaters. If your machine does not do theta pulse stimulation, does not mean that it's your excuse from not knowing about theta pulse stimulation. That's one of those objections that I have for the Clinical TMS Society, because they have a statement saying that, oh, ITPS, we're not sure about it. What do you mean? Like, you know, the whole society, the whole community of TMS physicians agree that ITPS is at least as effective as rtms. And that's based on a non-inferiority trial called 3D trial that was done in Canada, when it included 200 patients on each arm. And they did, 200 patients with rtms, 10 hertz stimulation, and they did 200 patients with intermittent theta pulse stimulation. And for the duration of 20 treatment sessions, meaning 4 weeks. And both groups had the same response and remission rate, okay? So that was a non-inferiority trial. I usually joke and I say, if I tell my wife that I am not shorter than Tom Cruise, what does that mean? It means that I might be at his height or I might be taller, okay? So if Tom Cruise is 5'6" and I'm 5'8", then I actually am taller than Tom Cruise. But that's not what I told my wife. I told her I am not shorter than Tom Cruise, right? You know, to keep a little bit of a mystery in there, right? So a non-inferiority trial proves that theta pulse stimulation is not less effective than rtms. Could it be better? Of course it could be better. I don't know. We did not continue beyond 20 treatment sessions. You know, if we went for 30 treatment sessions, it could be better. We only did 600 pulses. What if we did 1800 pulses like Sandpaper did, you know, like accelerated TMS with theta pulse stimulation doing 1800 pulses? We could be more effective than rtms, right? You know, so at least it's not less effective than rtms, okay? So that's what we know today, all right? Okay, the other ones, the second option, ITPS is better than rtms in treating TRD. I cannot say that yet because we don't have head-to-head trial, but in the future, we might be discovering something that, hey, maybe theta pulse stimulation is a better option. Again, that's against the stupidity of the Clinical Standard Committee at the Clinical TMS Society, who still did not resend a statement that they published back in 2019 saying that we're not sure about ITPS. You know, it's because of your ignorance, you know, it's not because of a problem with ITPS. All right, third option, ITPS is more expensive than rtms. No, it's not. It's actually cheaper, because you're using less time on the machine, so the decay or the the damage that you will cause to the machine, you know, because you need to replace the coil after a certain number of pulses or what have you. So the cost of ITPS is actually less than the cost of rtms. Okay, that was one of the reasons why Neurostar and Brainsway did not want to add ITPS function to their machines. They continued to be resistant all the way until last year to kind of open up their machines for theta pulse stimulation. And here's a hint. I think the reason why they ended up giving up and getting the approval for ITPS for their machines is because of the work from Dr. Nolan Williams with accelerated TMS and the Sandpaper being so impressively good. So they just wanted to kind of be there in case that it gets FDA clearance, so they can jump on it and say, oh, our machines can do the same thing as well. But that's a different discussion for a different time. All right, the fourth one is ITPS takes longer time than rtms. No, it takes less time. So, you know, for an rtms session, it would take about 18.5 minutes. For a theta pulse stimulation session for 600 pulses, it would take about 3 minutes or so. If you're doing 1800 pulses, it would take about 9 minutes or so. All right, let's look at this next question. Stacy finished 30 treatment sessions of TMS. Her MADRS score was 40 before TMS, and today her MADRS score is 28. What is the best recommendation for Stacy? Number 1, start 6 sessions, taper off TMS over 3 weeks. Number 2, no taper off for her, no taper off for now. Follow up in 2 weeks. Some patients might see improvement after treatment course is over. Number 3, refer for deep TMS. Since rtms did not work, then deep TMS can work better. Remember I told you I call deep TMS diffuse TMS? Okay. Number 4, order TDCS device that is better than rtms for depression. All right. So here we have a patient who finished her treatment course of 30 treatment session of TMS, and her MADRS went from 40, which is severe depression, to 28, which is moderate depression. For her to go through taper off TMS, the MADRS score should be at least slashed by half. It should be 20 or less. Since this patient's MADRS score did not decrease by, to 20 or less, then she did not really have a response to TMS. Okay, I apologize. Did I click on this one? No, that's not the one. No taper off. Okay. All right. So since this patient did not respond to the treatment, then we cannot really justify a taper off. Okay. So for now, we don't do taper off. You have a couple of options. Option number 1, which is what I do in my clinic, is that I just extend for another 10 treatment sessions, because some patients could have a late response. Why did we decide to stop at 30 treatment sessions? There are a couple of papers that showed, and I know that I mentioned that in a previous video, and somebody asked me for those papers, and I actually, attached those papers into the response comments in there. So go review that video and look at the response comments in there. So for some patients, 30 treatment sessions might not be enough. So I usually extend for another 10 treatment sessions and see if I can drop this number from 28 to less than 20, and then I will do taper off, okay? If you are working for a company or like Greenbrook or somebody, and you don't have, authority over extending treatments for free and, doing it pro bono for patients and what have you, or the patient, or you charge for that and the patient does not have the money or whatever it is, just follow up on the patient in 2 weeks, because technically they could have delayed response. And if they had delayed response, then yes, you can justify a taper off, right? Some could ask, what's the point of doing taper off if you already broke it out by 2 weeks? Then okay, then you don't do taper off if you're that concerned about like there was already a break. But the fact that the person had delayed response means that it doesn't really matter the timing as much as the number. Then I will add those 6 sessions, as a taper off later after that. Okay. But anyways, from the legal standpoint, for your contract with your insurance or for Medicare reasons, if the patient did not respond to the treatment, meaning that there is no 50% decrease in their depression scale, then you should not be doing taper off. All right. Let's look at this next question. All right. So Jacob is a 32-year-old male who called inquiring about TMS therapy. He had been depressed for the last 6 months. He did 12 sessions of cognitive behavioral therapy that did not help. His family doctor prescribed him Celexa 20 milligrams, which caused him ED, erectile dysfunction. He stopped it after 6 weeks. His family doctor then switched him to Wellbutrin and explained that Wellbutrin does not have sexual side effects. The patient felt extreme anxiety with Wellbutrin and decided to stop after 3 days. Okay, now Wellbutrin, it's not like it doesn't cause sexual side effects, it's less likely to cause sexual side effects, and sometimes we add it to SSRIs to decrease sexual side effects. Okay, but one of the side effects of Wellbutrin, because it increases dopamine and norepinephrine, is that patients could get agitated and they could get more anxious. Okay, so and that's what happened with the patient after about 3 days. He was referred to a psychiatric nurse practitioner who started the patient on Remeron 15 milligrams at night. I don't know why I said psychiatric nurse practitioner. I was just trying to blame the in response or the lack of response on lower level of care. I'm just kidding. Nurse practitioners are good too. All right. Okay, so 15 milligrams at night. The patient felt very groggy in the morning and could not drive to work. He stopped Remeron after 1 week. He went back to the nurse practitioner, who now prescribed him Effexor. This caused him erectile dysfunction again. The patient does not want to try any more medications and asked if Blue Cross Blue Shield will cover the cost of TMS therapy for him. Okay, so basically what I described to you in this question is intolerance of 4 antidepressant medications from multiple classes, from more than one class of medications. There was no augmentation, because you're not going to add augmentation to a medicine. The medicine is causing a severe side effect, right? And the answer to this question, yes, Jacob would qualify, because Jacob did not tolerate 4 antidepressants and he failed psychotherapy. Okay, so there was no augmentation in this quiz, because with intolerance you do not really need augmentation. Okay, you can read the other ones, like one of them is yes, because Jacob failed 2 antidepressants, augmentation and psychotherapy. No, there was no augmentation in there. No, because Jacob did not fail 2 antidepressants and augmentation and psychotherapy. Augmentation does not matter when we have intolerance. No, because Jacob did not fail 4 antidepressants, 2 augmentation and psychotherapy. Again, it doesn't matter, because it was intolerance. Okay, all right. All right, let's read this next question. Which of the following TMS protocol is used in SANTRD? Oh, that's the second question about SANTRD, right? Again, because it's getting a lot of attention media-wise, so we need to be aware of it. And I think it's going to be the future of TMS, so you need to be aware of it, okay? All right, so which of the following is the TMS protocol used in SANTRD? Number 1, frequency of 50 hertz, duration of 2 seconds, intertrain interval of 8 seconds, trains 60, pulses 1800, intensity of 80% of mirror threshold. Okay, so what are those numbers? Okay, so on the machine, when you're putting the numbers for your patient, you have a section that will tell you the frequency, and then you have the duration of that frequency being delivered, and then the intertrain interval, right? That's the separation between two trains of stimulation, and then the number of trains, and then the number of pulses, and then the intensity. Okay, I am going to refer to another video that I made, kind of showing the differences. It's a very boring one, but it's very scientific for the math of how you come up with those numbers. I'm going to refer to that, so you can watch it and understand what those numbers are about, okay? All right, the second option, frequency of 50 hertz, duration is 2 seconds, intertrain interval is 8 seconds, trains is 60, pulse is 1800, intensity 90 to 120% of motor threshold. Third option is all the numbers are the same all the way until trains, which says 20, pulse is 600, intensity is 90%. The fourth option is frequency 50, duration 2 seconds, intertrain interval is 8 seconds, trains 20, pulse is 600, intensity is 120. All right, so the answer to this question is the second one, okay? Frequency of 50, okay, so this is 50 hertz for the theta pulse stimulation. The duration, now those 50 hertz then are repeated in 5 hertz. That's where theta comes from, okay? So that's the topic of that other video I mentioned. The duration of how we're delivering those 5 hertz, which means 10 bundles, because 5 hertz meaning 5 bundles a second. So if we do it for 2 seconds, then we're delivering 10 of those, okay? So that's 2 seconds. And then the break between the stimulation to the next train of stimulation is 8 seconds. The total number of trains is 60 trains, and the total number of pulses is 1800. The intensity is 90 to 120 of motor threshold, adjusted to the cortex depth. Okay, what does that mean? Cortex depth means where do we put the coil and where does the brain cortex, the brain matter starts, okay? And for some patients who are older, they could have shrinkage of their brain and that distance could be larger. For those ones, we actually set it at a higher number of MT, okay? For patients who have shallow, they don't have that much of a shrinkage of the brain, that they have, higher density of brain cortex, and their brain cortex is closer to the skull, then we could be, at 90%, okay? All right, now, why was that done for sand? I have no idea, okay? The theory there is that, the more distance, then the less intensity or the less strength that you have at the cortex. But if we're gonna account for the distance, don't we have to account for gender? Like, male skull is different than female skull. Don't we have to adjust for age? Because as we age, our bone density is lower. And if our bone density is lower, we're gonna let more of the magnetic pulses, go in. Aren't we gonna adjust for race? If somebody has a curly hair, thick hair, that could, dissipate more of the magnetic pulse. So for me, it made no sense other than adding more gimmicks, to the device or to the protocol to achieve that unique patent, for Stanford, accelerated intelligent neuromodulation therapy. And I know, they're the scientists. I'm not, but I'm gonna tell you now that this is a gimmick. In my patients who I do accelerated TMS for, I just set it at 120%. Because this is still safe. This was within the safety charts to do 120%, and I don't have the gimmick of adjusting for the depth. And I don't believe that you can just choose one parameter, which is the depth, and adjust for it and ignore all the other parameters. So for this reason, I just set it at 120%, and that's how I do it. Okay. All right. Next question. Jessica called Florida TMS Clinic and said the following: can I make an appointment? What is the best reply? Okay. Well, that you don't care about this question. This is more for my staff. The first option is, are you looking for TMS? Number 2 is this for TMS? Number 3 is, we only see patients for TMS. And number 4, would you like to tell me more to see if we can help? All right. So, this is more of a communication skills question. Basically, as a TMS treater or technician or what have you, you need to learn more about your patients. It's not about like, oh, we only do TMS in here. Yeah, we specialize in that. Patients most likely don't know what TMS is, right? So, they called your office, for some reason, meaning that they need help. try to understand what's going on. Okay, so would you like to tell me more to understand what's going on? And they were like, well, you know, I've been trying on so many medications and nothing is working for me, and I came across this TMS thing, and I'm not sure if I want to do TMS or just want to see the psychiatrist, you know, for consultation to kind of explore this more, right? So then you're going to be helping the patient of like, okay, well, let me get you to see the psychiatrist. At least he will advise you if you're not a good candidate or something of the sort. Okay, so be empathic, you know, learn about your patient. It's not about doing TMS for people or not doing TMS for people. It's just one of the tools that we use for treatment-resistant depression. So you know, being empathic and actively listening to your patient is way more important than, you know, whether you use this technology or use this other technology, or you gave a medication, or you did, you know, psychotherapy, or whatever you did. You know, learn about your patient. All right, next question. All right, in the scalp simulation shown in the picture, which landmark would you target to treat depression with high-frequency TMS? So, you know, those landmarks are basically what we use for EEG, and I'm asking, you know, which one of those that you would use to treat depression with high-frequency TMS. And the answer to this question is F3. Okay, so F3 correlates per beam method, correlates with the DLPFC. Okay, so F3 is on the left side, F4 is on the right side. So when I ask about this, you know, and I'm asking about treatment for depression with high frequency, we want F3. Okay. All right, what about F4? F4 is on the other side, so anything that is odd numbers is on the left side, anything that is even number is on the right side, right? And anything that's Z and letters and what have you is basically on the midline, okay? So if we're going to the other side in there, that's what we would use for low frequency TMS for the reason of depression or anxiety on the right side, okay? But for this question, it's F3. All right, who invented TMS? Again, it's a general education question. I'm not sure, you know, how important it is for you to know or not, but it is. I think we have to give credit to people who added to this field, you know, over the years. Okay, so who invented TMS? Is that Mark George? Is it Anthony Parker? Is it Nolan Williams? Is it Elon Musk? Okay, the last one, Elon Musk, is just for the joke reason. Okay, Elon Musk is going to advance the future of neuromodulation. I think, you know, one. Not that I'm saying I'm diagnosing a celebrity with bipolar disorder, autism spectrum, and a little bit of narcissism. Not that I'm saying that, no. And not that he needs to find solutions for those problems that he has. I'm not saying that. It's unethical for me to say that, and I'm not saying it, all right? I think he invested a lot of money in a startup called Neuralink. That's for, like, you know, neuro microchip technologies, you know, to kind of implant devices and try to kind of collect more data from the brain and see if we can neuromodulate anything, you know, to kind of solve some neuropsychiatric problems. I know how scary that sounds. I understand all of this, but at least somebody is investing in there. Even if it did not come up with anything, it would teach us something about the brain in the future. Okay. All right. Enough about Elon Musk. This is not about Elon Musk and Tesla and what have you. This is about who invented TMS. TMS was invented by Anthony Parker, okay, in the United Kingdom, and that was back in, I think, 1985, and I am born in 1985, so this is how old TMS is. When he invented TMS, he was more looking into a device to treat multiple sclerosis and movement disorders, and he was doing single pulse TMS at that time, meaning giving only one pulse at a time. And I think a few years later, and he did not patent his invention. The main reason, the critical reason that Anthony Parker, he had two other partners who worked with him at that time, but the main reason that he decided he's not going to patent, you know, TMS is that he knew that if he did, that will slow the invention and the rollout of TMS to become a medical device that people can use, and that would delay things by 5 to 10 years. So he decided that for the good reason of humanity, you know, to kind of make sure that people have access to this as soon as possible, that he elected out of, you know, patenting the invention, okay? All right, I repeat, he did not patent the invention because he wanted more people to use TMS. And if he did patent it, then it would be a slower rollout of the technology. Well, who is patenting TMS right and left nowadays? Everybody in the United States of America. And that is, there are so many lawsuits from one company to the other company, and you will see, like, you know, news about $18 million to buy licensing about neuronavigation from one machine to the other machine, and it's a shit show. I'm sorry, excuse my French. It is really a terrible environment, you know, to kind of be in today compared to what Anthony Parker had done in the past, okay? All right, so who's Mark George? Mark George is basically the godfather of clinical TMS for depression. I think he was doing a fellowship in the UK related to neuroimaging, and that's when he came across, you know, TMS and, you know, with Anthony Parker and what have you, and then he brought this to the NIH, and thanks to him, TMS as we know it with conventional TMS, the 10 hertz stimulation for 5 days a week, 6 weeks for 30 treatment sessions, he's the one who designed it this way. They were doing pilots under his directions. They were doing pilot trials, of how many sessions we need for duration and what have you, all the way until he came up with this protocol. And that's what made it to the pivotal trial that was sponsored by Neuronetics, and that's what made it to the pivotal trial that was sponsored by the NIH. Okay, so Mark George is a big name in TMS, and he advanced TMS, taking it from the raw neurological device to what we use now for mood disorders. Who's Nolan Williams? I think he is the second godfather now of TMS. He's the modern version of Dr. Mark George, taking all that we know from neurostimulation and trying to advance it, to a higher level, so we can actually deliver TMS in a shorter period of time and increase the efficacy of it. He's a head of a neuromodulation lab at Stanford University. All right, okay, so TMS was invented by Anthony Barker. All right, next question. In the EEG brain illustration shown in the picture, which landmark would you target to treat anxiety with low frequency TMS? Okay, so I think I already hinted to that when I answered the previous question for high frequency TMS, and in this situation it's low frequency TMS, so it's F4. Okay, so that's what I was talking about with odd numbers being on the left side of the hemisphere and even numbers being on the right side, and F3 based on beam method, which takes in consideration EEG electrodes placements. The F3 one is the one that we use for high frequency on the left DLPFC, and F4 is what we use for right low frequency DLPFC. Okay. All right, next question. The R in rtms stands for regular, routine, repetitive, rapid. Okay, I know, silly questions, I apologize, but if you don't know what TMS stands for, you should not be practicing TMS, okay? And when you add R to that, what does R stands for? It stands for repetitive transcranial magnetic stimulation, okay? Why is it repetitive? Because we're given, those 10 hertz for about 4 seconds, and then we're taking a break for 26 seconds or 11 seconds, depending on the protocol that you're using. So there is a repetition that we're doing, and then we're breaking in between those repetitiveness of the trains, okay? This might be a good time to kind of talk a little bit about different types of TMS. Do you want to do that? Okay, I'm back. I made a little bit of like a handwritten note. I apologize for my handwriting. I'm a doctor after all, so that's one of the trademarks that they teach us in school. How to write really terribly. All right. So TMS, transcranial magnetic stimulation. It could be either a single pulse TMS. That's when I told you that Anthony Barker, when he made his machine, initially it was single pulse. Like you give one pulse at a time, similar to when we were doing the mapping, right? And then we made it repetitive rTMS. Okay, a repetitive transcranial magnetic stimulation, meaning give it multiple pulses, in a sequence, and then stopping and then going again. That required cooling system, because when you're inducing a magnetic pulse in a machine, you're going to produce heat, and you need to cool down the coil to be able to reproduce that magnetic stimulation again and what have you. So machines had to be more advanced to be able to deliver repetitive transcranial magnetic stimulation. Okay, all right. So now repetitive transcranial magnetic stimulation could be either high frequency, anything that is more than 5 hertz, hertz meaning how many pulses per second. So anything that is more than 5 pulses per second is considered to be high frequency, or low frequency. So anything that is less than 5 pulses per second is considered to be low frequency. So for example, the pulsation or the frequency that we use for the reason of an anxiety is 1 hertz, right? 1 hertz, low frequency TMS, right? Technically, it's also continuous low frequency rTMS, because we don't stop. We go all the way for like those 15 minutes or so. While with repetitive transcranial magnetic stimulation, we take breaks. So we do 10 hertz for 4 seconds, and then we take a break for 26 seconds or 11 seconds before we repeat it again. This is similar to if you're going to the gym and doing reps, right? So you're doing reps, those are the 4 seconds, right? And then you're taking a break, and then you're doing another set of reps, right? And then you're doing that on a daily basis and what have you, okay? So now high frequency TMS could be divided depending on the frequency you're using, okay? So if you're using the around alpha wave kind of rhythm, then you're using 10 hertz, right? And that's what, most of our machine, this is the FDA-cleared, protocol for figure of 8 coils, right? If you're using 18 hertz, which I think what BrainsWay uses for their machine for high frequency, then that's also high frequency repetitive transcranial magnetic stimulation, right? And then you have theta burst stimulation. Theta burst stimulation is 50 hertz of a triplet of a pulse. So the 3 pulses are at the frequency of 50. But then you're repeating that in a frequency of 5 hertz. Those bundles, you're repeating them at a frequency of 5 hertz, meaning 5 per second, okay? So those because you're doing it in that 5 hertz, this is theta wave in the brain. So that's why it's called theta burst. Again, there is a detailed video about that, that I'll upload at some point, okay? All right, now that theta burst stimulation, sorry, maybe you're out of the window now. Okay, all right, okay, hopefully you can see the rest of this. Okay, and now that theta burst stimulation could be either intermittent theta burst stimulation. That's what I told you when we're actually, going for those 2 seconds. So we did it in 5 hertz, meaning 5 bundles per second. We did it for 2 seconds. So those are 10 bundles basically, and then we stop for 8 seconds, and then we repeat the same thing again. So that's called intermittent theta burst stimulation. So that's where intermittent theta burst stimulation name came from. Okay, or it could be continuous theta burst stimulation. So we're doing those bundles, at the frequency of 5 hertz, but we're not stopping. We're gonna go all the way in for two minutes in a row, and then break for a minute, then do it another 2 minutes, and that could be inhibitory, and that could help with anxiety. Okay, so again, let's start from the tree from the beginning. Okay, so we have TMS. TMS could be either single pulse. That's what I told you about the initial machine that was made for TMS. Movement disorders and possibly TMS and what have you. So it could be single pulse, or it could be the machine that we use for migraine headache. I think it's called Spring something. I forgot the name of the manufacturer that does the single pulse occipital TMS device. Then you have repetitive transcranial magnetic stimulation. Repetitive transcranial magnetic stimulation could be divided into 2 sections: high frequency repetitive transcranial magnetic stimulation or low frequency repetitive transcranial magnetic stimulation. Low frequency repetitive transcranial magnetic stimulation is what we use for the right DLPFC treatment. Okay, high frequency could be 10 hertz stimulation. That's what we use in machines like Neurostar, MagStim, MagVenture, NextStim, all those kind of machines that use figure of 8 coil. Or it could be 1800, it could be 18 hertz stimulation. That's what I think BrainsWay uses, for their high frequency TMS. And then you have theta burst stimulation. Theta burst stimulation means triplet of a pulse at a frequency of 50 hertz, but repeated in bundles. Okay, that could be either in ITPS fashion, meaning that we're going for those 10 bundles in 2 seconds, and then we have a break after that. So that's intermittent. Or it could be continuous theta burst stimulation, that we're continuing those bundles all the way without stoppage after that. Okay. Hopefully this clarifies the classes of treatments. Did you see anything here that says DTMS? No, because DTMS is branding exercise. It has no place in my tree here of explaining the different types of TMS. It's technically here. They're using 18 hertz high frequency rtms in H coil, but H coil is a shape of TMS. It's not a protocol of TMS. Okay, so I don't want you to confuse what BrainsWay does with the classes of protocols of frequencies of treatments. It has nothing to do with the frequency. It has to do with the shape of the coil. Okay. Okay, all right, so after this poor handwriting kind of explanation, let's go to the next question. Which of the following TMS protocol is FDA cleared? rtms, frequency of 10 hertz, duration of 4 seconds, intertrain interval of 26 seconds, trains 60, pulses 2400. Nope, incorrect, because the total number of pulses should be 3000 and the total number of trains should be 75. Next one is rtms, frequency of 10 hertz, duration of 4 seconds, intertrain interval of 8 seconds, and trains 75, and pulses are 3000. Incorrect, because the intertrain interval that is FDA cleared for rtms is either 26 seconds or 11 seconds. Okay, it's not 8 seconds. 8 seconds is for intermittent theta burst stimulation. It's for ITPS. All right, next one is theta burst stimulation, frequency of 50 hertz, duration of 2 seconds, intertrain interval of 8 seconds, trains of 20, and pulses of 600. Correct. This is the one that takes about 3 minutes. This is what's FDA cleared based on the 3D trial that was done in Canada. Okay. Number 4, theta burst frequency of 50 hertz, duration of 2 seconds, intertrain interval of 8 seconds, trains 60, and pulses 1800 pulses. That's the SANT protocol. It's not yet FDA cleared. I think it will be FDA cleared in the next few months, but as of now, it's not FDA cleared yet. Okay? All right. Okay, let's go to the next question. Which of the following is not depression rating scale? MADRS, HAM-D, BDI, Y-box. So the answer is Y-box. Okay, why do I want you to know this answer as a TMS treater or technician or what have you? Because for the reason of OCD, if your clinic does provide DTMS, whether through H7 coil or through DB80 coil from MagVenture, then you're not going to track that with depression rating scales. You need to track that with OCD rating scales, and for this reason it's Y-box. Okay. All right. Next question. Jack has TRD. TRD is treatment-resistant depression for many years. He's on medications and is in therapy, both of which are not helping. He had tried ECT 2 years ago, which did not work well for him. He's wondering if he can do TMS. What is the best statement? Okay, so the question here is that somebody has treatment-resistant depression, meaning that he had tried medication, psychotherapy, did not work for him. He ended up doing ECT, which is electroconvulsive therapy or shock therapy, and it did not work for him. Okay, now the question is, TMS won't help Jack because ECT did not work. No, there is no, I do understand the principle of like, okay, it's neuromodulation, and the best neuromodulation we have is ECT. Then technically, if it did not work for him, then TMS is not going to work. Clinical data does not support that. There are patients who would benefit from TMS who had tried ECT before and it did not work for them. And you know what's the greatest example of that is the work from Nolan Williams, with sandpaper. The pilot trial for SANT, before SANT, the paper as we know it, is out. When they did a pilot trial with 6 patients, all of them had failed ECT in the past. 5 out of those 6 responded. Now, all of them relapsed later on after a little bit of time, so durability was not the greatest, but those patients had failed ECT before and they responded to TMS. So that was a breakthrough, okay? All right, TMS can work for Jack despite previous failure to ECT. That is the correct answer. TMS risk of seizure is higher for those who had ECT before. No, unrelated. TMS risk of headache is higher for those who had ECT before. No, unrelated. Now, why did I mention this? Because ECT could cause headaches, right? So I don't want you to kind of confuse the fact that ECT could cause headache, that, this means, high risk of headaches or what have you. Those are unrelated. Okay. Let's look at this next question. All of the following are TMS manufacturers except for one. Neurostar, Neurospa, Neurosoft, Neuronetics. Okay, this question, I know, like, why do you need to know this as a TMS technician or a TMS therapist and what have you? I understand. But you need to distinguish the manufacturers who provide or who make the devices from clinics that actually provide the treatments, okay? So when a patient, calls you and you're discussing with them, okay, where did you do your TMS before? And they tell you, I did it at Neurostar. Well, Neurostar is a manufacturer. They have sold over 700 shares, I think, since they opened or what have you. I think Brainsway has like over 800 shares sold or something of this sort. So those manufacturers are selling devices. They're not really the clinic, okay? So you need to be aware of the names of manufacturers, so you don't end up, writing down names of manufacturers thinking that you're, getting the names of the clinics. Why do you need to know the name of the clinic, for a previous TMS treatment? Because one of the criteria for approving TMS for a patient is response in the past. And to prove response in the past, you need to acquire those records from that previous clinic and show that the rating scales did show improvement as patients went through their TMS treatment. So we do that a lot, with the office from, patients who come from Dr. Kenneth Pages in our area, or patients who had been treated in another state in the past. Sometimes other clinics will request records from us, like our colleagues at Neurospa and what have you, for a patient who had treatment at our clinic before. So we send them those records, so it would make it easier for them to approve the patient for a second course of TMS. Okay, so manufacturers are Neurostar, not Neurospa. Neurosoft, they make the device called Cloud TMS. Neuronetics, they actually make Neurostar, okay? So I know that I put neuro just to kind of confuse you in there, but if you're paying attention, you would know the answer. Okay. Next question. Donald is a 67-year-old male who is suffering from depression for 2 years. He tried more than 4 antidepressants from 2 different classes of antidepressants with 2 augmentations and cognitive behavioral therapy without improvement. He has a managed Medicare plan through Humana. Which of the following statements applies to the need of prior authorization before starting treatment? Okay. So remember when I told you Medicare, you do not need prior authorization before you go with TMS? Well, what if the patient has a managed Medicare plan? Then the answer is yes, you need prior authorization from Humana, because they're managing their Medicare plan in this situation. Look, insurance is complicated, and managed Medicare is one of those things that I think are debatable, and my opinion is negative about managed Medicare plan, because technically Humana in this situation, when they're managing Medicare, their job is to save money, right? And to save money, they won't delay care for some patients, because if somebody came in for TMS and they qualify for it and you start them next week, then you're delivering the care. But if you needed prior authorization, what is that? This is an obstacle for the clinic to kind of submit the papers, for the insurance to kind of review the papers. Nobody is making mistakes. They look at the things, everything makes sense. They will call you back. You're not missing the call. You're saying yes, we approve them, and then the patient is starting treatment. That process will take a couple of weeks. Now your patient, might be dead. Might have committed suicide already, right? It's terrible, the whole idea of prior authorization, particularly in mental health. In mental health, we barely get patients to do anything, right? One of the, trademarks of depression is anhedonia, no interest in doing anything. And finally, when you get somebody to kind of decide, okay, I'm going to do something about it, and then you're telling me, oh yeah, but not today, come back in a couple of weeks until we get a prior authorization from your insurance. So based on that, when you add obstacles, you spend less money, right? So that's the whole idea of managed Medicare. Okay, so I apologize to say that, but I think it's a complete rip off of the system. Having such a component. I can tell you multiple sad stories of what happened to patients because of delay in care, because they had a managed care plan similar to those who were an obstacle in the patient getting their treatments. Okay, let's look at the next question. One of the following insurance does not always cover TMS therapy. Which one is that? It does, again, you have to kind of look at your local area. This is for Florida. Optum, they do cover TMS. Anthem, they do cover TMS. Magellan, they do cover TMS. Sunshine Medicaid in Florida, unfortunately, they do not cover TMS. Now, we were able to convince Sunshine Medicaid with a couple of cases, to do TMS, but I think even one of them, they retroactively, they said, you know what, we don't want to do it. We want our money back because we don't have criteria for TMS. And that, Medicaid particularly is dependent on your state. So the more, this is not politics, please don't take it as politics, but the more Democrat your state is, the more likely that your local Medicaid will cover for TMS, and the more Republican your state is, the less likely that Medicaid will cover TMS in your state. Okay, hopefully, the spending on healthcare and what have you would be out of politics, and it would be more oriented by the public need, and will be independent of political opinions about what we're doing and what have you. But that's basically a rough estimate of how Medicaid covers and does not cover TMS. So if you're listening to this and you're a decision maker, or you can make a difference about that, please try to make a change in here. Try to force a Medicaid, local Medicaid in Florida to cover TMS. And again, I said Medicaid, I did not say Medicare. Medicare always covers TMS, okay, in any state, okay? Medicaid, the state insurance for low-income patients, is the one that is, kind of giving us a hard time. All right, next question. All of the following are TMS manufacturers except for one. Why am I repeating this again? I don't know. Oh, okay, for the Fisher-Wallace thing. Okay, so McVenture is a TMS manufacturer. Maxim is a TMS manufacturer. Mag & More is a TMS manufacturer. They're based in Germany, and they make a machine called Apollo. I really like how it looks like, but it might not have the best cooling system in there. I told you about Maxim. This is what we use in here. It's made in the United Kingdom. And McVenture is, I think, Danish company that's made in the Denmark. And it's also a good company. It's a good device, okay? And I throw Fisher-Wallace in there because Fisher-Wallace is not really TMS. It's not transcranial magnetic stimulation. Okay, I repeat again. Fisher-Wallace is not TMS. Why do I need to make this statement? Because unfortunately, this particular manufacturer does misleading advertisement on Google, okay? So if somebody is Googling TMS therapy, something is going to show up. In the past, a couple of years ago, before I complained about that, but in the past it would say TMS therapy for a few $100s instead of $10,000, right? And then it would land you to Fisher-Wallace. Well, it's not really TMS. It's TDCS, or as somebody corrected me before, it's TACS. So we'll talk about that, in a separate video, the difference between TDCS and TACS, okay? But the bottom line is, then they adjusted their marketing to say alternative to TMS. No, it is not an alternative to TMS, okay? TMS is FDA cleared for severe depression, okay? Basically treatment-resistant depression, if it fails 1 in 10%, which is treatment-resistant depression. Fisher-Wallace does not have evidence that it helps with severe depressive episode. It does help with mild to moderate depression if we stretch the evidence. If we stretch the clinical evidence, it does have, some benefits in mild to moderate depression. It is not for severe depression. So we're talking about completely two different animals, okay? Severe depression that is treatment resistant, you can use TMS, okay? Fisher-Wallace is not an alternative. It's a completely different thing, okay? All right, so that's why this question is in here. I apologize for for being a little bit more emotional about this question. All right, let's look at this question. George had been doing TMS for 3 weeks. Today he comes in for his regular TMS session. In the middle of his treatment session, you notice that George is shaking all over his body. He's unconscious. What is the first thing to do? Okay, so I repeat, this is a person who's doing TMS. He had been doing TMS for about 3 weeks or so. In the middle of the treatment session, he's shaking all over his body and he's not responding to you. He's unconscious, okay? What is the first thing that you have to do? Number 1, move the TMS coil away from the patient head. Number 2, turn off the TMS machine. Number 3, call 911. Number 4, remove the patient mask to make sure nothing blocking the patient mouth and nose. If the patient was wearing a mask, this is COVID time. Hopefully by the time you're watching this video, people are not, don't have to wear masks anymore. Okay? All right. Now, the key there is that all 4 of those things are necessary. You need to call 911. you need to move the coil away from the patient head, you need to turn off the machine, and you need to make sure nothing is blocking the patient mouth, for safety of respiration. But the key there is, which one do you do first, okay? I asked here, what is the first thing you need to do? So think about it for a second, okay? Well, basically you should know this answer and never think about it. You have to know exactly what you're going to do when a patient has a seizure, okay? This is a patient who has a seizure, and you're the TMS technician, and then you notice that the patient is having a seizure while on TMS. What is the very first thing that you have to do? The answer is turn off the machine, okay? That is the quickest thing that you can do, okay? So usually there is a very big button that is shown on the machine that you can just click and turn off the machine immediately, okay? So this turning off the machine is the quickest thing that you can do without wasting too much time while the patient is having a seizure. If you pick the choice for moving the TMS coil away from the patient head, that might take a few seconds longer than just turning off the machine, okay? And that could be a little bit more complicated if you were using Brainsway, the helmet design device, because that one attaches to the patient head and there is a strap around their neck, and if they're seizing, it's going to be very hard to take that thing off, okay? So wasting your time until you get the coil off of the patient head, that is going to take you at least 10 seconds with such a coil, okay? Even with our coil, which is figure of 8 coil, that we can simply just squeeze something and take it away from that, those are a good 3 seconds, and I don't want to waste this much time. First thing, I want to turn off the machine, okay? You turned off the machine, you take the coil away. Why do you want to take the coil away? So the patient, when they're seizing, they don't hurt their head, okay? And then the third thing is going to be making sure that there is nothing blocking their mouth and the patient has appropriate breathing airway, okay? And then you have to call 911. You send the patient to the hospital. They would do some basic testing, making sure that the patient, usually the seizure will stop in about 3 minutes or so, and patients, will be safe. They will either monitor the patient for 24 hours in the hospital, or they could release them home, okay? All right, let's look at the next patient. Compared to rtms, which of the following statements best describe DTMS? Okay, we talked about DTMS already. So let's read those statements and see which one is correct. Number 1, DTMS is less effective than rtms in treating TRD. Number 2, DTMS carries less risk of seizure than rtms in treating TRD. Number 3, DTMS stimulates larger area of the brain than rtms in treating TRD. Number 4, DTMS is more tolerable than rtms. Okay, so probably from the previous questions that we discussed before, you know the answer already, which is number 3, which is DTMS stimulates larger area of the brain than rtms in treating TRD. Okay, so why did I put this question? Because of some of the information that Brainsway puts out there, and I want you to be aware of it, so it doesn't kind of confuse what you're trying to achieve with your patient. The first choice here, which is I'm going to call it deep TMS, as I told you. I think it's diffuse TMS, the better descriptive terminology, but I'm going to call it what they call it, which is deep TMS is less effective than rtms in treating TRD. No, it's not less effective. Actually, there was a paper that was for a clinical trial that was done in Croatia that showed that deep TMS has higher response rate, but remission rate is similar between figure of 8 coil and H coil. That paper is full of flaws. We'll talk about that in a different video, comparing figure of 8 coil to H coil. But the main thing is that the gender of participants was biased towards one area that will make the deep TMS group more responsive, and the other thing is that the remission rate was the same. It was a response rate that was different between the two. Okay, there was another data collection that was shared in the last Clinical TMS Society Chicago meeting for a significantly larger number of patients in the United States of America that showed no difference between figure of 8 coil and H coil. Actually, there was a little bit of advantage for figure of 8 coil, but I'm not going to comment on that. I just want you to know that it's not less effective. We have to assume that both of them are effective. Deep TMS carries less risk of seizure than rtms. Actually, it's a little bit higher risk of seizure than rtms. Both of them are very low, to a point of being almost negligible. But if we're going to put numbers and we're going to take chances and what have you, deep TMS has a little bit higher risk of seizure compared to figure of 8 coil. That being said, I'm talking about H1 coil, the one that goes to the left side of the brain mostly. It seems like double cone coil like H7 and H4 do not carry the same risk of seizure like H1 coil, and it could be because when we're stimulating both sides of the brain, we are keeping the stability of the activation of the brain. When we stimulate only one side, then we might induce a seizure then. All right. And then the last one, deep TMS is more tolerable than RTMS? No, absolutely not. It's the opposite. So the more diffuse, the larger the stimulation area of the head that you do, the more discomfort that you could have with the treatment, and the more headache that could happen. Actually, it causes more twitching of the face as well. So there is a recommendation of actually wearing a mouth block, like for teeth, so it doesn't damage your teeth. Some patients will have a little bit of problem biting their teeth during the treatment. That doesn't happen with figure of 8 coil. Figure of 8 coil is very local. It doesn't activate as much of facial nerves. All right, next question, also related to different TMS devices. Adam is a 55-year-old male who recently moved from New York City to Wesley Chapel, Florida. Wesley Chapel is like the fastest growing suburb of the Tampa Bay area. That's where my clinic is, and that's where our new house is going to be. We live in New Tampa now. Yeah, it's a very crowded area now. It seems like a lot of people from the Northeast are coming to Florida, which it's always been the case. But this last couple of years with COVID migration and what have you, it got really crowded in here. Okay, anyways. He suffers from TRD, and he had tried many antidepressants, augmentation, and psychotherapies in the past without success. He explains that the last year he went to a local TMS clinic in New York, and he had a full course of TMS therapy using a helmet-like machine called BrainsWay. So why did I put that? Because sometimes patients do not remember the name of the machine. They would tell you it looked like I was wearing like a bike helmet, so you would understand that was BrainsWay. Okay. He did not notice any improvement in his depressive symptoms. He wants to try a figure of 8 coil TMS. He said, oh, well, I was reading online that maybe Neurostar is better than BrainsWay, okay? And he has United Healthcare, Optum. He asked if TMS therapy would be covered under his insurance plan. What is the most accurate statement, okay? So technically, this is somebody who had done TMS on one machine, he did not respond, and now he wants to do it on a different machine, and he's asking, is my insurance gonna pay for it? Unfortunately, no. Okay. All right. So let's look at the choices. Number one, insurance will cover TMS therapy because he was approved before. He has to improve with TMS. So the fact that he did not improve last time, will get him out. Number two, insurance will cover his TMS therapy because he failed H1 coil before, but not F8 coil. Okay. It doesn't matter which coil he fails, whether it was H1 coil or F8 coil. It's still the same thing. It's still that he did not respond to TMS. And to be honest with you, I support that. Otherwise, it would be a kind of a mess, for somebody. Oh, well, it was because of the machine, and maybe if I am on... It's similar to when insurances will say, we'll pay for the generic of the medication, and the patient wants the brand name because of whatever reason. Well, clinical research is not really supportive of, a brand over a brand, as long as, it's still FDA approved with a certain amount of the active chemical in it and what have you, okay? All right, number three, insurance will not cover TMS therapy because he failed TMS therapy of any type, any machine before. That is the correct answer, okay? And last one is insurance will not cover TMS therapy because he did not go through the same clinic that he was treated at previously. It doesn't matter which clinic, he can still get approved if he had response before. But the main issue is because he did not respond before. Okay, let's look at the next question. All of the following are correct. Yeah, I'm sorry for the typo here. My grammar is not the greatest. I'm not sure if you noticed already or not, but I am not a native speaker of English. I learned English, so maybe that will excuse me here. All of the following is correct, but about maintenance TMS, except for one, okay? Maintenance TMS is off-label. Number two, maintenance TMS is done once a week, once every other week, or once a month. Number three, maintenance TMS is not covered by insurance. Number four, maintenance TMS is done for 6 sessions, okay? All right, so all of those are correct except for one, okay? So is it off-label? Yes, it is off-label. Maintenance TMS is done once a week, once every other week, or maybe once every month. Yeah, all of those could be correct. It depends on what your doctor decided on maintenance. Maintenance meaning that I want to do TMS continuously to prevent or to increase the durability of the treatment or to prevent a patient from relapsing back into depression. So I usually would pick once a week, for a while before I would go for once every 2 weeks, okay? But some doctors go with once every month. Number three, maintenance TMS is not covered by insurance. That's also correct. Insurances would not cover maintenance TMS. Number four, maintenance TMS is done for 6 sessions. No, not particularly for 6 sessions. You can do maintenance TMS for as long as you want to do it. 6 sessions is for taper off. So the key in this question is for TMS technicians or treaters, therapists, doctors, what have you, to understand the difference between taper off and maintenance, okay? So taper off, after you're done with 30 treatment sessions, you can do taper off of 6 sessions in 3 weeks. Those are 3 sessions in week number 1, then 2 sessions in week number 2, then 1 session in week number 3, okay? All right, let's look at the next question. Wanda has depression and anxiety. She's on Xanax 2 milligrams 3 times a day. She got approved to start TMS next week. She asked, is my Xanax going to affect my response to TMS treatment? What is the best answer? We talked about this before, right? You know, and I'm repeating it again because it's so common for people to ask this question. And it's also, I think, at some point, a good practice to kind of bring this up whenever you're evaluating a patient for TMS and you notice that they have too much of benzodiazepines in there, okay? So the first answer was no, Xanax would not affect the chances of response to TMS therapies. This is wrong. Number two, possibly, Xanax can decrease your chances of response to TMS. You should stop it. Okay, that is incorrect, okay? Because if she stops it, she's at a high risk of seizure now, okay? So that was another educational point of this question, is that you don't want to risk somebody going through withdrawal, particularly that her dosage is 2 milligrams 3 times a day. She's taking 6 milligrams of Xanax every day. If you tell her to stop it and then she starts TMS, she's at a high risk of seizure. Number three, possibly Xanax can decrease the chances of response to TMS therapy. Don't stop it abruptly, because withdrawal from Xanax while doing TMS can increase your chances of seizure. So that is the correct answer. You know, yes, it could decrease your chances of response to TMS, but I don't recommend that you stop it abruptly. So what are we going to do? Well, it's one of two choices. Either that you and the doctor will work on a taper off schedule before you start TMS, and given it enough time before you start, TMS, say, you decrease it from 6 milligrams in a day to 4 milligrams in a day, in about a couple of weeks, and after that to 2 milligrams in a day in about a couple of weeks or a month, and then you start TMS at that point, so then the chances of seizure is going to be significantly less. By the way, if that patient was an elderly patient, like over 65 or maybe 70 years old or something of this sort, we have to taper off even more slowly, because, discontinuation or withdrawal from benzodiazepines in an elderly patient could be ugly, okay? And we don't want an elderly patient to be on this much of benzodiazepine. This is bad, this is not a good thing, I generally, as a general rule of thumb, once somebody is requiring more than 2 milligrams equivalent of a benzodiazepine, we have a problem, right? As long as we're within 2 milligrams, then it might still the benefits might be over the risks. Okay, fourth one is possibly Xanax can increase the chances of response to TMS therapy. Absolutely not true. Okay. This is an interesting question. All right, so TMS can be effective but not FDA cleared for treatment of the following psychiatric disorders except for one. So what I'm telling you here is that there are 3 that TMS would help, but it's not FDA cleared for. Okay, one is not going to be helpful. It's not FDA cleared, but it's not going to be helpful. Okay, so you need to pick the one that is not going to be helpful. So that's delusional disorder. Okay, so far we don't have data that TMS could be helpful in delusional disorder. Okay, so can TMS be helpful in bipolar disorder? Most recent episode is depressive. Yes, we talked about that in a previous question, right? If somebody had been depressed for 6 months, a year, there is no manic episodes, we have tried antidepressants to bring the patient up and it did not work, and we want to try TMS, yeah, sure, why not? Insurance are not going to pay for it. It's not FDA cleared for that reason, but there is enough literature support to kind of use TMS for the reason of bipolar depression. Okay, generalized anxiety disorder. Yeah, you can use low frequency TMS on the right side. Actually, you can use even high frequency TMS on the left side, for the reason of generalized anxiety disorder. If you remember, anxious depression is FDA cleared. So I did not say anxious depression, which is major depressive disorder with anxious distress. That one already is FDA cleared. The question was not FDA cleared, but it could be useful. Okay, so that's generalized anxiety disorder. It does fit this criteria. PTSD. Yes, it could be helpful. We use low frequency, usually low frequency right-sided TMS for the reason of PTSD. Could be helpful, it's not FDA cleared. Okay, so the one that is not helpful and not FDA cleared is delusional disorder. Okay. Next question, TMS is FDA cleared for treatment of the following psychiatric disorders except for one. By the way, disclaimer, this is August of 2022. Things are gonna change month by month, okay? We're getting a lot of indications, stacking up, for TMS over time, okay? So as of now, of August 2022, what is TMS FDA cleared for? MDD, correct. OCD, correct. Acute psychosis, incorrect, okay? Cigarette smoking, correct, okay? So MDD, all of the TMS machines that we have, the 7 TMS machines that I mentioned before, are FDA cleared for this one. OCD, currently, Brainsway has OCD clearance, and McVenture for DB80 coil has FDA clearance for OCD. And just last month, Neurostar from Neuronetics, they got an FDA clearance for the regular figure of 8 coil for OCD. I'm like, oh my God, what does that mean? Because for Brainsway, they had to come up with a provocation, before therapy, before treatment, and what have you. And they were like, oh, our coil is completely different than H1 coil because we're stimulating bilaterally and it targets those areas and what have you and stuff. For Neuronetics, they did not create any new coil. They just got an FDA approval for their previous coil. So I am very looking forward to read, the FDA clearance document. I did not see it yet. I think it was just a few weeks ago that this announcement was made. So I need to see the document to kind of see like what is the treatment protocol and what have you. Acute psychosis, as I told you, it's not FDA cleared by any machine. You could use, there is some, I think in Europe, they use a TMS for negative symptoms of schizophrenia, okay? Negative symptoms of schizophrenia. That's not acute psychosis, okay? So that's why I chose my words wisely in here when I was making the choice. The fourth option is cigarette smoking. Yes, that's H4 coil from Brainsway. It has an approval for smoking cessation. And that I think is going to be the next breakthrough in TMS, because addiction had been a big problem and still active problem, still an issue, but our lack of treatment options for addiction had been a big issue. So hopefully that will have a little bit of a breakthrough. All right, next question. As of July 2022, insurance requires between 1 to 4 antidepressant trials prior to prior authorized TMS therapy for their members. Which one of the following insurance requires 2 antidepressant trials? Okay, so this question again, I put as of July 2022 because there was something about Medicare being updated pretty soon. Okay, and again, all of those questions I made more to fit Florida, but basically the question is which one of those insurances requires 2 antidepressant trials. Okay, United requires 4. Florida Blue requires 4. Magellan requires 4. Cigna requires 2. Okay. All right. So just familiarize yourself with all the criteria for insurances in your current clinic, in your current plan. Okay. In this picture, you can see illustration of different coil designs and resultant areas of stimulation. Which one represents figure of 8 coil? Okay, I love this one because it shows you, like, if we have a magnet of this shape, right, like, what is the area that we're stimulating. Notice that underneath the donut is where we have the red area. This is the highest amount of stimulation that happens. Okay, all right. If we're using 2 donuts next to each other, then the connection point between the 2 donuts is the higher or the maximum intensity of stimulation. So if I want to be very precise of where I want to stimulate or deliver my magnetic pulses, then I want this shape. I want figure of 8 coil, okay? Because then I know exactly where I'm stimulating, okay? Notice that all other shapes are not as accurate. So this could represent H coil, right? This is how, like, the wire will go, cross over, and it go again, right? So that's what I was talking about with the H, right? Notice that the area of stimulation is very diffuse, and it doesn't go underneath, the center of where we're going. And that's why I told you, when it's in a helmet design, even when we tilt it towards the DLPFC, it means nothing, because it's still going to stimulate, large enough area that it even touches the right hemisphere in stimulation. This shape in here is basically the DB80 coil, or the double cone coil. So if you're looking, this one, number B, is basically the H1 coil. The number F in here is basically DB80 coil from McVenture, or even H7 and H4 coil has a component like that from Brainsway, okay? And in that one, you see how it's kind of, first, it's stacked up in the wires in a way that it looks like a cone if it continues forever, and it's also angled in about 130, 140 degrees, to kind of give the maximum penetration. This will give a lot of depth into the stimulation that we're doing, but at least it's very specific for what we want to stimulate, okay? All right. So this question is asking which one is figure of 8 coil, and then you have to specify it's D, okay? And this is how the coil would look like, and that's how the area of stimulation looks like. Okay. Next question. Lisa called asking for express TMS. She explains that she saw a billboard on the highway that says Express TMS for depression only available at whatever clinic. What TMS protocol does Express TMS refer to? Okay, so Express TMS was a brand name created by McVenture when they got the FDA approval based on the 3D trial I told you about, from the Canadian paper. Okay, so that's for Theta burst stimulation. All right, so because it's a very short period of time, only 3 minutes, so they called it Express TMS, or I think the other name for it was I don't remember. Yeah, but but they came up with that brand naming, and then they tried to kind of publicize it this way, which, to be honest with you, patients don't really care that much about, like, 3 minutes versus 18 minutes. I think what matters more is that when we shorten the duration to 3 minutes, that opened the space to kind of go for maybe 9 minutes with 1800 pulses within safety, and that's what opened the door for accelerated TMS. So I think it opened the door for multiple treatments in a day rather than just one treatment a day, because if you're sitting on the chair for 18 minutes or 37 minutes with the old protocol, then this is too long for you to do multiple in a day. All right, so which one is Express TMS? Basically, it's this one here, the third one. Frequency of 50 hertz, duration of 2 seconds, intertrain interval of 8 seconds, and trains 20, and pulses 600. Okay, Fisher-Wallace stimulator, I know, I'm repeating the same idea in here. So Fisher-Wallace stimulator is an rtms, TDCS, ECT, DBS. Okay, so it is TDCS, but again, somebody corrected me recently, telling me that this is not really TDCS, it's actually TACS. Okay, so what is the difference? So it seems like T is transcranial direct current stimulation. So T is transcranial direct current stimulation. So you know how you have for electricity you have direct current and you have alternating current, DC and AC. Okay, so alternating current, is basically what we use from the the power outlet, usually in houses and what have you. And then usually you will translate that into direct current, for whatever you're doing, for whatever machine you're using and what have you, like, DC charging stations for Teslas and for Electrify America and what have you. You're trying to deliver electricity in the same form that your car is actually taken, so that's why it's faster, okay? While at home you need to change from AC to DC, or you're actually plugging in an AC, and the charger in your car is translating that to an electrical current that will charge the battery, okay? So that's why you cannot really be that fast. All right, so anyways, if I'm putting 2 electrodes on someone's forehead and I'm delivering electricity in a direct current, it's different than if you're delivering that in alternating current, or at least based on what that person was explaining to me. How is that useful, from the clinical standpoint? I don't know yet, okay? So I am going to explore that more, and I'm going to kind of provide you with a little bit more detailed video about that. But so far what I read from the FDA when they, to see the clearance for Fisher-Wallace, they classified that under CES, which is, I want to say cranial electrotherapy stimulation or something of the sort, okay? Or current electrotherapy stimulation, okay? CES. So they did not distinguish between TDCS and TACS. Okay, so I might change this question to TACS instead of TDCS. Okay. Next question. Sarah is a 20-year-old female who had been experiencing depression since March of 2020. She tried counseling at church, which did not help. She had never tried antidepressants before. She refuses to try any antidepressant medications because her mother used to be like a zombie when she was taking medications. She wants to try TMS therapy. Which of the following statements is most accurate in describing TMS therapy for Sarah? Okay, Sarah should not have TMS therapy unless she had tried antidepressant medications. No, that's not correct. Sarah can have TMS therapy, but it's off-label use because she does not meet FDA clearance indication. That is the correct one. Remember when I told you the FDA clearance is trial of 1 antidepressant in the past. This lady did not try any medications. So can she try TMS? Of course she can, but it's just going to be off-label. Sarah can have TMS therapy and her treatment is on-label use indicated per the FDA clearance of TMS therapy. Incorrect. Sarah can have TMS therapy, but she need to do genetic testing to prove her intolerability of medication. Nope, incorrect. So that's a question that's important. One person would say, you know what, doctor, I'm not going to try 4 antidepressants to prove that I'm intolerable of medications because I am generally intolerable of any medicines. Like when they give me antibiotics, when they give me blood pressure medications, I don't tolerate them. So why would antidepressants be any different? How about you do genetic testing and then you prove to my insurance that I have intolerability of medications? Well, unfortunately, as of now, though genetic testing could be a good, useful tool to choose medications, but we don't have clinical correlation that is associated with that. Meaning that if I do your genetic testing and it's telling me that you're not going to respond to these medications, but you're going to respond to these medications, and I take that indication or I take that advice over what I would have done clinically, there is no science that this is better. There's no science and there's no data that this is better. Okay, so though the raw information of genetic testing seems to be promising, but as of today there is no clinical use of it. Okay, I'm saying this because if this patient tells you just do genetic testing and show that I am a slow metabolizer, insurances probably are not going to take it this way. Now that being said, I did have a patient with severe genetic problem that we did peer-to-peer, and we bypassed that intolerability based on the genetic problem that the patient had that made her intolerable of medications before. But it's not a standardized way of doing this. All right, next question, which is one of my favorites. Okay, what is the cost per remission of 30 treatment sessions of rtms therapy? Okay, is it $6,000 something something? Is it $11,000 something something? Is it $3,600 or is it $15,000? Okay, why am I putting this question? All right. cost of TMS is an important topic for you to understand. And why is it important as a TMS technician, therapist, treater, to understand? Because you need to know that though TMS is expensive, the alternatives are even more costly, okay? Being in a hospital for a week costs more than any of those numbers, okay? Being on a new brand name medication with an augmentation, like, if you're on Trintellix and Vraylar, your bill every month is over $2,000 to your insurance, and you do that for 6 months, 12 months, you're already burning $20,000. If you were taking esketamine, Spravato, which is, one of the treatments that we do at our clinic, for treatment-resistant depression, the course of treatment is at least $20,000 to your insurance as a cost, right? And I'm saying that, by the way, and I know that there are leaders in the clinical TMS society who do not understand this concept. I remember, one of the meetings or one of the expert panel that was talking about accelerated TMS and how accelerated TMS would cost like $10,000, for the treatment. And like, oh my God, this is a ripoff for patients. How would we allow, people to be charged, $10,000 is so much money when you can do Spravato and it would cost the patient nothing. And I'm like, okay, how is this doctor, where did you get your economics education? Like, this is not how it works. Spravato cost about $20,000 to the insurance. And who is insurance? Insurance is basically employers like me buying insurances for my staff, or Medicare. So this is our tax money. So this particular leader is thinking that, because the last transaction was not involving the patient, it was involving the society paying $20,000 for Spravato. So because the last transaction was less than the last transaction of accelerated TMS of $10,000, then that it was a rip-off for a doctor to charge $10,000 for accelerated TMS, which is completely un-American. In America, we're all about freedom of choice, and people can do whatever they want to do with their money. If I think that my nose is ugly and I want to have a nose job, and then I find a plastic surgeon and I pay $10,000 for my rhinoplasty, and I'm happy with that, who are you to stop me from doing this, or to stop my surgeon from doing this, right? But when you take the taxpayer money, and then you force, somebody to change their nose or their organs, or I don't want to get to the gender, part of things, or what have you. When you take someone else's money and you spend it on, a treatment that you're not sure about and what have you, that's a bigger problem. Or that's where we have to talk, right? Okay. So why am I telling you all of this? Because I need you to understand that the cost of treatment is a factor into why insurances will provide or cover a treatment and would not cover a treatment. I think some of our subscribers for YouTube, ask this question. I'm like, no. Insurances are not here for charity. What they do is like, okay, if I tell me the cost per remission of doing 30 treatment sessions for TMS, meaning how much money do I pay to get one patient remitted? And the answer here is about $6,000 for rtms, and it's about $3,600 for Theta stimulation, okay? And this is basically how the reimbursement is going to be set. They set the reimbursement closer to the cost per remission. So let's give me one more example, and then we will conclude this one about the cost, okay? If we're talking about hepatitis treatment, and then we come up with a new medication, right? And then we want to price how much can we charge for this medication. Well, tell me how much money I'm gonna save the healthcare payer by providing this medication. And based on that, you will give me, the reimbursement for the medicine, okay? And based on that, those medications were costing about $80,000 or something like that for a course of treatment over 80 days or 90 days. Recently, there had been a new treatment for thalassemia, a blood disorder that I think the treatment per patient will cost about $2.8 million, right? A huge number, right? But if you're thinking about how much cost you have saved the taxpayer or the healthcare payer in this situation, it would be equivalent, right? And if we don't do that, then nobody is going to be innovative, and nobody is going to come up with new treatments and what have you for difficult to treat diseases like that, particularly for rare diseases when you don't have that many people who have it, okay? All right, so the answer to this question, the cost per remission of 30 treatment sessions of rtms is $6,000, okay? The I in ITPS stands for intensive, intermediate, invasive, intermittent. So the answer is intermittent. Go back to the question that I, drew like diagram of like, types of TMS. Let me see if it's still out there. Okay. Yep, here it is. Okay. Okay, so if you remember in this one, I was telling you the different type of TMS. And you have single pulse TMS, repetitive TMS, high frequency, low frequency. High frequency is going to be 10 hertz, 18 hertz, or theta burst stimulation. And theta burst stimulation could be either continuous theta burst stimulation or intermittent theta burst stimulation, meaning that we're delivering those triplet of pulses in a certain frequency, and then we're taking breaks in between them. Okay, all right. Next question, which of the following medications is an antidepressant? Okay, why am I asking this question? Because I want you to know, I want you as a TMS technician or a therapist to know your medications. I want you to know what are antidepressants, which classes are they. When you're reviewing or when you're submitting the prior authorization and you're sending it to the insurance company, you need to know that they actually met the criteria, okay? So Klonopin is not an antidepressant, Flexeril is not an antidepressant, Ativan is not an antidepressant, Trintellix is an antidepressant, okay? So, talk to your doctor, get a list of medications, make sure that you understand the classes and, keep that in mind and practice it with your colleagues. Make flashcards about it and kind of try to practice names of medications. That's how my staff did it, and I'm very proud of them. They know, their medications really well. They know how to do the prior authorizations. I don't do that many peer-to-peers, because of how great my staff are in my office in knowing those kind of details. Which of the following TMS therapy treatments coils carries the highest risk of seizure? Okay, so that's back to the question about different coils. F8 coil by MagStem, H1 coil by Brainsway, H7 coil by Brainsway, H4 coil by Brainsway. Okay, so the answer to this question is H1 coil by Brainsway. Remember when I told you, H1 coil delivers what they call deep TMS, and it's actually diffuse, and the more diffuse the area that you treat, the more side effects that you will have, and it carries high risk of seizure. Does that apply to H7 and H4 coil? No, it's higher in H1 because it's unilateral, or trying to be unilateral, so it stimulates more of the left side of the brain than the right side of the brain. It seems like H7 and H4 don't carry the same risk, or not as much of a risk. And F8 coil, figure of 8 coil, for sure has less risk of seizure. All right, next question is, which of the following is the FDA-cleared -rtms protocol? Okay, so the classical rtms protocol is the one that takes about 37 minutes or so. So then it was shortened into half that time by decreasing the intertrain interval. So and that one decreases the intertrain interval from 26 seconds to 11 seconds. Okay, let's think about this for a little bit of time. When the first machine was made, the cooling system was not that effective at that time, and you needed a little bit longer time to cool the coil in between the treatment sessions. So for this reason, they were doing 10 hertz stimulation for 4 seconds, which means 40 pulses, and then the intertrain interval, the break in between those pulsations, kind of being delivered, was 26 seconds. And we did that for 75 trains, and the total number of pulses was 3,000 pulses. Then after the machine was more advanced, and then you can cool the system, faster, we cut down the intertrain interval to 11 seconds. So that's the second answer in here, which is the correct one. 10 hertz stimulation, 4 seconds, that's 40 pulses. Break of 11 seconds, repeating that for 75 times, that gives you, 3,000 pulses, okay? All right, the other ones are, the third one is for Theta burst stimulation, that's FDA cleared, and the last one is for SANT protocol, which is not FDA cleared. All right. What is the main distinguishing character of ITPS, or intermittent theta burst stimulation? Okay, and then it gives you 3 options, and I have a little bit of a illustration in here, just in case that you want to see, the different the main characteristic in here. Number 1 is triplet pulses. Number 2 is continuous pulses. Number 3 is reaches deeper structure. Number 4 takes longer time. Okay, so the main thing with theta burst stimulation is that we're delivering triplet of pulses. Pulse number 1, number 2, number 3. At a frequency of 50 hertz, okay? So that triplet of a pulse is the main characteristic of theta burst stimulation. Now, that bundle is repeated, you see that bundle, is repeated on a frequency of 5 hertz, okay? And that's where the word theta came from, okay? So we're delivering basically 3 in here, separated, the whole train is about 200 milliseconds, so we can do 5 of them in 1 second. And we continue that for 2 seconds, so that would be 10 of those bursts, and then we take a break for 8 seconds, and then we repeat it again. Okay? All right. So, but the main characteristic of theta burst stimulation is triplet pulses. All right. Which one of the following TMS clinics provide deep TMS in the Tampa Bay area? Okay, so take that question and adjust it to your market, to your area, to where you practice. Okay, so if you're in California, New York, what have you, and you provide, figure of 8 coil treatment, and then there is a patient who needs deep TMS or diffuse TMS or Brainsway treatment or whatever it is, you need to know which clinics in your area does provide that, so you can refer them to. Okay, particularly for the reason of OCD. Okay, so if somebody has a significant component of obsessive compulsive disorder and you want to use H7 coil or DB80 coil, you need to know who those are. Okay, so in our area, Florida TMS Clinic does not provide deep TMS, not at this point. That might happen soon. TMS of South Tampa, that's my colleague, Dr. Kenneth Pages. He does not have deep TMS either. Solace Behavioral Health, yes, they do. And TMS of Tampa, they do not. Okay, so the answer here is Solace. But, that question is related to my staff. For your own staff, design that question in a way that they know what they're talking about. They know, like, who are their neighbors, what do they provide, and then in case that patients needs a service that you do not provide, that they can send them there. Okay. Which of the following TMS coils and machines is FDA cleared for the use to treat OCD? Okay. All right. So H1 coil, no, it's for depression. H3. There is no coil that's called H3. There is a machine from Maxim called H3, which is Horizon, third generation, basically. They call it H3. If I were in their shoes, I would avoid anything that's related to H. I don't want to be associated with Brainsway. H4, that is the one that we use for smoking cessation, right? And DB80 coil from Invention, yes, it's used for OCD. So notice the trick that I did in this question. I mentioned a lot of H's, but not the correct H, right? So H1 is the one for depression. H3 is Horizon third generation from Maxim. It's not a coil. H4 is the deep TMS or the Brainsway coil for smoking cessation. And the correct answer would have been H7 for the OCD coil from Brainsway, but I did not mention that. I mentioned the coil from McVenture, which is DB80, which is basically also FDA cleared for OCD. Okay, all right. Okay, so hopefully this quiz was helpful for you. Again, it's not about, right answer, wrong answer. It's about like, okay, what do I know about TMS? How could I use my knowledge to help my patients who are coming to my clinic and make sure that I have enough knowledge to manage the basics of what I need to manage. Obviously there is more knowledge to be obtained, and this would be more of like a curiosity provocation kind of quiz for you to kind of learn a little bit more and dig deeper. On our website we have so much data about every aspect of what I mentioned in here. I had a blog post about what is navigation, navigated TMS and the different methods of navigations. I have one page that just talks about Theta stimulation and all those details that I kind of showed you and what have you. Go there, learn, see, you might add something to the improvement of TMS over time. There is nobody who is too small for TMS or too big for TMS. Okay, so just keep an open eye and do your best, and share this with somebody else who could benefit from it. That's all. Thank you very much.